Mm. Hi, Llewellyn.
How are you, John?
How you doing?
I'm all right, thanks. How are you?
Very good. Very good. How are things in your corner of the world?
Yeah, we're going on, trying to find space and make sense of things as we go along.
Yeah,
And you,
it's not ending soon. Of course, I was like everybody else. I thought we'd be over this a year ago.
Yeah, absolutely. It's crazy, John.
Yeah, yeah.
I want to introduce you to someone quickly. I see Girish Solanki has joined.
Yes.
Girish, I don't see your video, but you're unmuted. Girish, can you hear me?
Colin, can you hear me?
Yes,
Yeah.
I can hear you.
I'm actually in my office clinic, and
Okay.
for some reason the webcam doesn't seem to be working. I'm not sure why.
Okay, are you on a smartphone or iPad?
Desktop computer.
A
It is a-
smartphone. You have to turn the camera on. At the bottom of the screen, there should be an icon like a camera. So to tap on that.
Yeah, no. I've tried that several times. It says Zoom is unable to detect the camera.
Oh, okay. Well, reboot. Start all. Turn your computer off completely and come back in.
Okay.
Come back. Yeah, turn it off completely.
Okay, let me try that. Okay, thanks.
Okay,
I think that's probably what I'll have to do. So
Okay.
you guys in a short while.
All right, Jim.
Hello, Harshad. Are you there?
Hi, John. How are you?
Good. How you doing? This is
I'm doing very well.
This is Harshad. He's a neurosurgeon from Mumbai, a frequent visitor of educational neurosurgery videos.
Yeah. No,
Matter of fact, he's doing his second residency in Zoom.
Yes, I'm learning again.
That's it. You thought you were done with the classroom. Well, I guess the doctor never feels that way, really.
Yeah, no, absolutely. How are things going, John? I see you're quite busy.
Things are going well. Things are going well. Just trying to learn the technology better, because there are a few facets to this. There's a marketing and there's a promotion and distribution. I mean, it's not, I mean, you guys, you're busy enough. You make the video, but other people should do things like distribute it and market it and promote it.
Yeah, yeah.
And
Sure.
you guys provide the hard stuff, the material. So it looks like you have a good one today.
I think so. I think so. You have any idea how many registered, John?
A lot more than I expected. More than 500, I think. Let me check.
Okay.
Yeah, it's the most I've had for a while. $445.
Wow, that's quite a bit, hey, John.
Yeah, that's good. That's good. That's good. Of course, we won't have that many because a lot of people sign up and don't come. But that's more of a higher number than I usually get.
Okay. Oh, that's nice. Nice to see.
So
let's wait for Girish to try that again.
you haven't done any traveling, right?
No. My first potential traveling is maybe in October, but to Houston or to Austin. Sorry for the CNS, but I'm not so sure I want to do that yet.
Oh, okay. Yeah, I think everyone's in the same boat.
Yeah.
I think it's unwise to book final booking.
There's no way I'm doing that.
I thought I was going to go to Mexico in November, but it doesn't, like the Delta is making a comeback in Mexico.
Yeah.
but it's not a virulent a strain as the original COVID, the Delta in Mexico. It's not as serious, and it affects younger people. So it's a change from the regular COVID, but it's
Sure.
not as serious, which is good news.
Good news, yeah. And what's it like? I see the States is having a bit of an upsurge now in numbers.
Yeah, in Florida, Florida and Texas are the two states in the whole country that rates are going up because there are pockets of people not wanting the vaccine, and those compose 99% of the cases. Now, I mean, that's science. I mean, it's a good thing to get the vaccine because you're not going to get COVID. In other words, there are very few cases of people that get vaccinated that get COVID. But there are still a lot of people that believe, the vaccine is poison, can cause problems. And unfortunately, Florida is one of those areas. So there's kind of like a rollback to what happened before. We're putting masks on more, not a lot more, but I can definitely see a difference when you go in public of people still being vigilant.
Okay.
How about where you're at? South Africa and Cape Town, right?
Pretoria.
Pretoria, okay.
Yeah, so look, I mean, a little bit, the same actually. I think a lot of people have been vaccinated, nowhere near the number we'd like, but always skeptics, and not everyone convinced that it's as good as it's made out to be. But that's
Yeah, I saw a map yesterday of the US of new cases, and it perfectly coincides with the unvaccinated areas. I mean, it's like a mirror image of the unvaccinated areas. So, and some people are wanting to make it compulsory. There are some companies like Netflix that are making it compulsory for the workers to have the vaccines. So I guess it would be tough for government to do that, but companies can do it. They can do what they want.
so I think Girish is back. John, shall we just get him to test the
Yeah,
presentation?
let's say, okay,
I'm still struggling with.
okay, you want to try it again? It looks like you're making progress because there you go, you got it.
Okay, perfect. Give me 2 seconds.
Well, don't call me a genius. All I know is the word reboot.
Yeah. Now that we can see you, Girish, I'm not sure it helps too much. I have to say that.
Okay. Okay, how's that now?
It's beautiful, beautiful.
Okay, good, fantastic. Thanks for that tip. Yeah, it was really helpful.
Yes, it's good to just reboot. That's the first thing you should do with anything with a computer. Reboot it.
That's right.
Who's the first speaker? Oh, we have 20, we have lots of time. We have 25 minutes.
Girish, you want to test your talk a little bit, or you were happy?
It should be all right.
Have you done a PowerPoint before?
Yeah.
Okay, well, go ahead and do it.
He's done one before, but we invited him anyway. So.
Oh, okay.
Okay, let me see.
Well, how do you guys know each other?
Yeah, know each other. I know that degenerate. Leave her in. Just 1 second. Let me see if I can bring the presentation. I have to read.
Is there any more presenters here that want to test their?
John, I don't see others. Not yet.
You're monitoring, right? Well.
Yeah, I'm having a look there. I see. So Mohammed says he's joining in another 5 minutes. So I'll give you the name. There's Belu Shehu, who will join John, and then Moody Qureshi.
Yeah, I'm going to make you co-host. That means you can let people in and stuff. Okay.
Can you see the slide?
That looks great, good.
Is it showing on show mode, or what's it showing?
Now you need to click on slide presentation mode.
New share. Let me just see if I can find it.
Where is that,
At the
Llewellyn?
bottom right of your screen there, Girish, if you drag your mouse down, come
Oh,
down.
it's up at the very bottom, right?
Is it sharing at the moment? Can you
It's
see?
showing, but it's not in presentation mode, I can see the side panel still.
Oh, I see. Okay, let me see if I can
That's it.
run
That's
it.
it. That's it. There we go.
Okay. But it's gone into new share. Let me just do a new share.
Yeah, I don't seem to see the option at the bottom that usually appears. Oh, there it is. Yeah, do you see at the very bottom of the screen to the right below there, there's a couple of icons. Click the far left icon.
Yeah, no, I know that, but so the problem is it's loading on the wrong screen. So I'm just trying to change.
Oh, okay.
It selected one screen as my.
Okay.
I'm just going to stop the share for a second. I apologize.
Okay, you can do it again.
I'm working with two screens.
Oh, okay.
It's loading the presentation on the other screen. That's the problem.
Well, the same principles apply essentially to make it in the regular size.
Absolutely. Okay, let's see now. Let's see if I'm lucky. Share screen. Content from second camera. Let me see if I can. Let's see if I wanted to drag. Yeah, it's gonna keep showing me on this one. Oh, yeah.
Girish, can I give you a tip that worked for me? If you click on the presentation and drag it from one screen to the other, so physically drag it across your screen.
The pointer screen, yeah?
Yeah, just grab the whole presentation, and then drag it across from one screen to the other.
He's not letting me do that.
You're not letting me, okay.
For example, I can drag.
Just open it then. Open it however you can open it.
Yeah, once a point is selected, it only allows you to click it, unfortunately. But I'm just trying to see content from second camera, advanced, basic. It's selecting screen 1, screen 2. Okay, screen 2. And yeah, and then let me just it'll allow me to, yeah, I think that might just.
You could do what you did before because it was on the screen.
Yeah. It unfortunately.
Okay, you're screen sharing. That's good.
Yeah.
Okay, perfect. It's perfect. Perfect.
Beautiful. Beautiful.
The only
Okay.
problem is it's not in front of my face.
Yeah. Okay. Okay. Are you the first speaker, Girish?
I am, yeah.
Okay. You're going to have to get off that so we can introduce. So Llewellyn can introduce your face. But you remember how to do it, right?
That's good. Yes, sir.
Okay, so just get off the screen. Yeah, I'll get you off.
No worries.
Yeah,
I mean, usually you can, yeah, okay, thanks very much.
yeah. Yeah. So just want to repeat it again? Want to do it again?
No, it's okay. I'm just trying to see what, normally on the share screen, you can, if you choose advanced, you can use a portion of the screen. There it is. So
there you go. Okay, you're screen sharing.
yeah, that's right. So if I do that, then I should be able to.
Now, okay.
Yep. And
You haven't opened your PowerPoint. Looks like you're on your desktop, on your. There you go.
John.
Okay, now make it big.
so if I can, the problem is,
Do what you did before to make it big.
yeah, so the problem is once I run it, it goes to the other screen. So let me see if I do this and run it from here. Now, damn thing always goes back to this screen. It seems to favor screen one. I wonder if I can cast it to the other screen.
John,
Yeah, we'll just let you stay on the, we're having a little trouble, so we'll let you just stay on your screen share. Well, but then I won't be able to introduce anybody else. Yes, Alon.
sorry, I see Mohammed's joined. He's under attendees. If you could maybe just move him across.
Yeah,
Well,
okay. Yeah, you can also, you will have the power to do that also.
All right.
I made you co-host.
Yeah, John, don't worry about it. I'll run this, the whatever, I'll do the presentation from one screen. It's just that I'll be looking sideways, but they should.
Okay.
I'll just stop the video and just focus on the presentation.
Don't worry, if we get clumsy, we can always edit it out.
Is the sound of it?
It's not going to be perfect.
Okay, perfect.
Hi, Mohammed, you get in? Okay.
Hi, everybody. John. Hey,
Yeah.
Girish.
Yeah,
How you doing?
Mohammed. Good to see you, buddy. Yeah, thanks for the invite, guys. I appreciate that.
Thanks for you.
Yeah.
Hi, Llewellyn.
Oh, how you doing?
Great.
Okay, Mohammed, and how you doing, Mohammed?
I'm fine, John. How are you?
Good. So you on the Wellon have a co-host. You can let people in. So if you see someone you want to come in, you put promote to
Panelist.
promote the panelists. Yeah. So if you see someone before I do,
Sure.
so we got the first speaker. We have the second speaker.
So Graham Fegan says he'll join in the next 10 minutes or so.
Okay.
Sandeep, and I sent him all the links. I'll check with him as well and keep an eye out, John, but doesn't join.
Yeah, we got 15 minutes.
I can see Vaishali. Is that you, Llewellyn, joining on your wife's computer?
No, I'm joining from my own computer. I see your granddaughter is the fattest, cutest pigs ever. Hey, Girish?
She's amazing. Huh? Everybody keeps saying that.
Yeah.
I'll have to distract you guys with something else now.
How are things otherwise with you guys up there? Okay.
Easy.
Busy.
We've been, because of the lockdown, we lost a lot of surgical time, and we're trying to catch up now. So there is something called surgical recovery for COVID. So we've been asked to do extra lists, just trying to catch up that way.
Right.
Situation back home?
Kind of the same, we've got a huge backlog. We managed to catch up in between the previous waves, but I think this one is a bit much, but we're hopefully now cruising into a bit of a lull. So we'll see how that goes,
Fingers crossed. And how's Cairo, Mohammed? Oh, Sandeep.
Yeah.
Hi, Girish. Hi, Llewellyn. Mohammed. Good. Hello. How are you?
How are you?
Just got on a flight and just descended at sea level from 17,500 feet where I was walking in the Ladakh Karakoram range.
Wow.
Oh, that's amazing.
Amazing.
So I'm going to just go and freshen up. I'm just straight from the airport, and I'll join you in a few minutes.
Okay.
So now let me know how you want to do this. You want to start off, then you can introduce Girish and I'll go Sandeep, and you can do Graham, or however you want to do it, Emma.
Yeah.
Girish, so you reckon about 45 minutes, yeah?
About 10 minutes.
And the talk, just wanted to check with Girish.
Oh, okay.
Is that all right?
No, that's perfect. We're just how's Charles Raybow? Girish, I know you know him quite well. Emailed him. I know he retired now full time from any bit of an echo there.
Is Charles attending today?
That's good.
No. I just I sent him an email a while back, and it said that he'd retired completely from tech.
Yeah, that's a real pity because Charles and I have some very similar views on Chiari. It would have been great for him to provide some radiological support.
I see Moody says he's online. Let me just find him. Okay, there we go. Okay, Moody, so I promoted you to panelist.
Hello, Alan.
Mood, how are you doing?
Good, good, man. How are you?
Oh, fantastic. Thanks so much for
Keeping
joining.
you guys busy. You asked for it, so.
What do you know Girish, right?
No, I haven't met Girish.
Okay.
Hi,
Girish is
Girish.
a pediatric neurosurgeon from Birmingham. Done
Okay.
all amazing things. Moody's the president of CAANS and you know, again, also done all sorts of amazing things. Yeah. So Moody, Girish.
Yeah, nice seeing you and nice meeting you, Girish.
My pleasure.
I think the video is not coming on, so that's
Is
fine.
it? Okay. And Sandeep Chatterjee? Do you know him, Moody?
Sandeep, I know we've met Sandeep, but
Okay.
Mahmood, do you want to test out your video? Can you turn it on?
no, it's not coming on for some reason.
Yeah, reboot. Reboot. You're
But I
probably not.
Come out and come in again. All right.
Come
Shall
in
I?
again. Yeah, reboot and come in the same link.
Okay.
For me, I had the same problem, Mohammed. John, you can make a lot of money with one word.
Yeah, reboot. Yeah, that's all you need.
Reboots.
I do it at all the webcasts. You know, some people think I know a lot of programming. I don't know any programming. I just know the word reboot.
Yeah, but you know the important words.
That's it.
Not doing it.
No, yeah, it's still. So you're clicking on the icon. Are you using a smartphone?
No, I'm using the laptop.
It's not recognizing your camera, huh? Go to the bottom of the screen where the camera is at, and toy with that camera option. There's a couple of things there next to that little camera at the bottom of your Zoom. Do you see that?
Yeah, the camera, that's the iPhoto. That's what it says.
Oh, iPhoto. Oh, so you're on an iPhone.
No. I'm on my MacBook Air.
Oh, okay. Well, I don't know where the menu would be. There should be an icon of a camera.
Yeah, there is an icon of a camera, but that says iPhoto.
Oh, so there's no options there to open it up.
Okay, let's see.
You basically want to get a menu open.
Don't worry, at least I'm not muted, so we can hear you guys, so that'd be good.
Okay, we won't make a big deal of it. Saeed, are you there?
Yes,
All right, welcome, Saeed.
thank you very much. How are you?
Good. Saeed is a neurosurgeon from Reunion, Africa, off the East Coast.
Yes, it's French department near Mauritius.
Near Mauritius. You're going to send me info shortly, right? On the next talk?
Excuse me?
Are you going to send me information on your next talk?
Yes, we'll have
Oh, that's kind of early. That's right.
Professor
Today-
Gaillard for
Yeah, today's one. Yeah, it is early. Yeah.
Professor Gaillard for Kochik adenoma, hypophyseal adenoma, and his experience with the cushion and acromegaly.
Okay.
Right. Hi. Evening, everybody.
Good evening.
Hi, Graham.
Hi, Moody. Hi, Girish. Hi, John.
Hi.
How are you, Graham?
Right, there it is.
Saeed,
Saeed. Hi, Saeed.
how are you?
Graham, do you need to test your presentation, or are you happy?
Yeah, let me just see
Okay.
if I can do that.
Okay.
We're in business.
Yeah. Perfect. Perfect.
Fantastic.
I see.
Okay.
You see how he did that, Llewellyn? He went to slideshow first, then he
Yeah.
went to home, play from start. You see that?
Yeah.
Right.
So that's a good thing to remember. Because usually I do it at the bottom.
Let's see if I get it right next time.
Okay, at the
I'm
very
not counting my
very
chickens.
top, it says leave screen share.
Okay.
Very top
Yeah.
of the screen.
Okay. Screen sharing's paused. Yeah. Okay. Cool.
There you go. Got it. So you're all set. Any other presenters you want to check with, Llewellyn?
Yeah, so Belush, there we go. Let me just get him up. I'll introduce him to you quickly as soon as he's up, John.
Okay.
Okay, quickly, let me just check with Mohammed. Mohammed. Mo, can you hear me?
Yeah,
Yeah,
Hi.
just quickly, how do you want to do this? Shall I kick off and then hand over to you, or you want to kick off and then I introduce?
okay, yeah.
Hmm?
Let's do it like this, yes. I would,
Okay, we got 1 minute. 1 minute.
Good evening, Mohammed.
hi, Graham, how are you?
How's it? How are you doing?
Good to see you.
Yeah, you too. Huh?
Hello, Graham. This is Bello.
Hey, Bello. How's it, Bello? How are you doing?
Okay.
Very well, yes, sir.
Wonderful. Nice to hear your voice.
Nice to see you.
Yeah.
Could you, Bella, do you want to turn your camera on? Is your camera on?
Okay, I'll check. No, okay, yes, I have.
There you go. There you go. Okay. I wish it was, Mahmoud, I wish it was that easy for you.
I wish it was for some reason. It's,
Oh, hi, Moody. How are you?
I'm good. How are you, Bill? Nice to see you. I'll just show you my picture that I took a few years ago.
Yeah, your picture.
Okay, Llewellyn, ready to go?
Okay, sure.
Okay, hold on. 10, 9, 8, 7. Good afternoon. This is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of broadcasting a CAANS Pediatric Neurosurgery Conference hosted by Llewellyn Padayaki, and pediatric neurosurgeon from Pretoria, South Africa. And I'll turn it over to him. Welcome, Llewellyn.
Thanks, John. Just a quick sort of correction there. So it's hosted by myself and Mohammed Al Beltagi on behalf of CAANS. Mohammed's from Cairo. So Mohammed, I'm going to hand over to you if you just want to introduce Bello and Moody to say a few words before we introduce the speakers, Mo.
Yes, sure. Yeah, hi, everyone. And it's our pleasure to have you again in this pediatric series webinars under the name of CAANS. We usually do it the second Tuesday of every month. and this is our 7th, I guess, webinar. It would be our pleasure to have always with us Moody Qureshi, the president of CAANS, and Bello. So please, Moody.
Yeah, thank you very much. Apologies for my video not coming on, but that's fine. It's always a pleasure to have eminent speakers come on and share their views and liven up the discussion. And this time we have the pediatric group coming in, and on behalf of all member societies of the Continental Association and all the young neurosurgeons who are tuned in, I'd like to say thank you very much. You guys have been amazing through this pandemic, and let alone the young neurosurgeons, I certainly have learned a lot. I hope I can retain it, given my gray cell becoming rare. But yeah, thank you very much for this initiative. It's I can see it's becoming successful. And Mohammed and Llewellyn, kudos to you guys. You persisted despite all challenges, and we're now seeing a regular series running. Thank you very much. Over to you, Bello.
Oh, thank you, Moody. Thank you. That's really great. I'd like to join you in really congratulating Llewellyn and Mohammed. And I think for CAANS, we cannot be more proud. These two people and the young neurosurgeons are really making sure we remain alive during this difficult period. I just noticed before you joined in, Moody, that there were some pictures of our senior colleague, a very close friend of ours and a strong member of CAANS, now unfortunately late Suad Bakhtar from Algeria. I am sure you and all of us will continue to remember a great lady doing a lot with the wing of CAANS and the CAANS itself. So we wish our family strength to bear her loss, and all of us as her friends. And once more, I'd just like to congratulate Llewellyn again, and I notice you have my own good friend, Girish Shalanki. We trained together in the UK in the early 90s. It's a pleasure to have him. As I told you, Llewellyn, pediatric neurosurgery, there's no continent that needs more pediatric neurosurgeons than Africa. We have the youngest population, I'm sure, in more than most of the continents. So this is really great, and I wish us all the best this evening. Thank you.
Thank you, Bello. Thank you, Moody, for this support as usual. And of course, we all remember Suad Bakhti, who passed away. She was an eminent pediatric neurosurgeon in Africa and in the CAANS and in the Pan-Arab also. And to start with our webinar, we are having 3 eminent speakers in this pediatric series, specialized on spine. This time, I will have the pleasure to introduce my dear friend, Girish Solanki. Girish is a consultant neurosurgeon at the Pediatric Regional Neurosurgery Center in Birmingham and Children's Hospital and the University Hospital of Birmingham NHS Foundation. He is an honorary senior clinical lecturer in neuroscience at the University of Birmingham and educator with the ISCB as the Regional Pediatric Neurosurgery Educational Supervisor. He was also previously the president of the ISPN meeting in Birmingham in 2019, one of the most successful meetings ever done by the ISPN. And he has also served in various executive roles in SIRE, ESPN, ISPN, PP, and G. Girish is widely respected as a leading international figure in pediatric neurosurgery with special interest in craniofacial surgery, Chiari Malformation, and pediatric brain tumors. It's a pleasure having you with us, Girish, as usual. A nice person, a great friend. So please, can you share your screen, Girish?
Hey, hi, can you guys hear me?
I can see you
Yes.
also.
Yes.
You can see me and hear me. Fantastic. Thank you. Very good afternoon or evening to all of you. It's a great pleasure to be with my African neurosurgery, brothers and, panelists and faculty at large. And thank you to the listeners and for your patience, because it gives me great pleasure to be part of this. I don't know if many of you know, I'm originally from Mozambique, a little area down in the southeast of Africa. And it's always great to share little pearls or learn from all of you in this sort of occasions. So thank you for inviting me, particularly Llewellyn and Mohammed. Congratulations on a great series. Also delighted to see Bello, my good friend. We shared a lot of happy and difficult times as registrars together in the UK and Ireland. Pleasure to meet you, Modi, and looking forward to hearing Sandeep's and Graham's presentations as well. So what I'm going to talk today is about one of my favorite topics, Chiari Malformations. I prefer to call it hindbrain hernia. And also wanted to tell you a little bit about the new algorithm that we've designed in Birmingham and have been using it for a while, and share some insights on this. So some of it is controversial. It comes from an old place, which is this hospital here. It's a grade 1 sort of monument. We can't change the facade at all, but inside good work goes on, as in many hospitals around the world. I have no conflict of interest. And this is a small summary of what we're going to talk today. The first thing I wanted to do is to start with the concepts of what is a malformation and what is a deformation, because we always talk about Chiari malformation. What are the physics of a hernia? Because a Chiari is really a hernia. How does it progress? What are the bases for rational treatments of hernia? And then how does a hernia progress? Particularly, how does a brain hernia progress? The concepts of supratentorial crowding and small posterior fossa as contributors to Chiari. And then other contributors, which we normally don't talk about, but it's very obvious. And most of us know that these things contribute to the association with Chiari and syringomyelia. So, and based on all of these contributors, we designed our algorithm for treatment. And I want to tell you a little bit about the natural history of Chiari, because often when somebody sees a Chiari, they jump on to treat it as if it is a serious malady that requires emergency treatment. And I think the natural history will inform us that this is actually not the case. And then talk a little bit about how do Chiaris progress, when we should treat them, are there different types of Chiari, treatment modalities, and so on, and a few publications to support the conversation that we're going to have today. And given time or during the discussion, we can look at some case examples as well. So the first thing to do is to start with the definition. So what is a Chiari? So I think everybody agrees now, and starting with Barkovich in 1986, that the limit is 5 millimeters below the foramen magnum. And that limit would kind of define a hindbrain hernia. Above that, it's borderline normal, and most people agree that nothing needs to be done. And then the second point I wanted to bring to you is this thing about malformation versus deformation. So malformation can be defined as a structural or functional anomaly that occurs during intrauterine life. These conditions develop prenatally. They may be identified before, at, or later in life, and malformations do not grow or progress in size as a tumor would. Deformations, on the other hand, are the action or process of deforming or distorting a structure or its shape, including flattening or elongation. And a deformation is caused by external forces over a period of time, and deformation can be progressive, stable, or regress as the forces that act on it, on the structure, change. And this is takes us then to what is a hernia. So a hernia is a condition in which part of an organ is displaced and protrudes through the wall of a cavity containing it. And examples of this is the intestine at the weak point of the abdominal wall, like an umbilical hernia, intestine through the inguinal ligament, an inguinal hernia, and the cerebellar tonsils through the foramen magnum, causing a hindbrain hernia. The basis for a hernia development in all cases is that you have to have two compartments. You have to have a connecting orifice. And all hernias are caused by a combination of pressure in one compartment with a widening of the orifice, essentially what you'd call an incompetent orifice, the one that connects the two compartments. And then the pressure pushes an organ or tissue through the opening or weak spot, and that organ or tissue then herniates into the second compartment. And the treatment objective of any hernia anywhere in the body is to reduce the pressure in the compartment with the herniating tissue. So if you get an obese person with a inguinal hernia, you'd want to ask the obese person to reduce weight before treating the hernia, and then tighten the orifice to reduce the hernia and prevent recurrences. And if you think about this, our current treatments of Chiari do not meet these objectives. We don't. Is everybody able to hear me? I think there's somebody that has got the mic on.
Yes, we can hear you.
Meet these objectives. The pathophysiology of Chiari Malformations, I think we pretty much all understand now, and particularly with the experimental models of Padilla and Padilla, the couple, they did a lot of studies which confirmed that Chiari 1 malformation is a primary paraaxial mesodermal insufficiency occurring after the closure of the neurofolds takes place. So basically, the photoccipital somite does not develop properly, and that leads to the formation of either a short stubby clivus or a small posterior fossa. And the primary factor, therefore, in the formation of hindbrain hernia is the small posterior fossa due to the underdeveloped occipital bone. So where the Indonesian line is, that drops down and your posterior fossa becomes really small. And the main objective of surgical treatment really is directed to restore normal CSF dynamics at the craniovertebral junction. So when you look at the natural history of Chiari, I think it was of great interest to me, looking at the large studies that were carried out on Chiari, particularly the one by Ben Carson, and you'll remember him as a presidential candidate. So he's a professor of neurosurgery at Johns Hopkins. So he and colleagues looked at something like 22,591 patients who underwent MRI imaging of the head and cervical spine. 175 were found to be clinically asymptomatic. So the extent of ectopia in this population was about 11.4 millimeters on average, and they were all significantly associated with the small cisterna magna. But syringomyelia and osseous anomalies were found in only one asymptomatic patient. Okay, so 14% of patients asymptomatic, syringomyelia and osseous anomalies in only one asymptomatic patient. Tonsillar hernia, 11.4 millimeters average. When I looked at this series, what I found, this is the 21 patients with anomalies. Only 6 children were actually under the age of 18, so probably not the representative sample for pediatrics. But the interesting thing was that there was a relation between the cisterna magna and the hernia. So if the hernia was 10 millimeters, the cisterna magna was okay. More than 10 millimeters, say 10 or 15, the cisterna magna reduced in size or became absent. Another study was the one from Professor De Rocco's team in Rome, and they looked at their series and they found that hindbrain hernias were incidental findings in 50% of their cases, and only 22% had clinical worsening. But the actual number that progressed to surgery was quite small, only 14%. So if you think about the number of Chiaris that we find, a very small proportion will actually end up having surgery or actually be symptomatic. So we decided to do a study because when I started pediatric neurosurgery, I was ignorant in a lot of things. And I wanted to understand these things for myself. So one of the things we did is to evaluate Chiari in the pediatric population in Birmingham. And I looked at the radiological progression of Chiari by a number of papers that were coming out at that time. And these two are from 2011, a good number of patients, but the follow-up was quite small, 2.83 and 3.8 years. And they reported a progression of the Chiari in 3.2% and 9.5%. So I think it looks like the longer they followed up, the greater the progression. There was no report of any regressions, and 90 to 96% of the Chiaris had not changed over 3 to 4 years. And then subsequent studies, for example, De Rocco had 22 patients but his follow-up was greater, 5.8 years. And he reported a 14% progression rate and a 5% regression rate with a 72% no change. We carried out the study in 2013 of 62 patients with a mean follow-up of 5.2 years, a progression of 9.7 and a regression of 3.2%, suggesting that the longer you follow patients, the more change you're going to notice. And as you know, there is a sort of a bipolar presentation of Chiari's in young children, as well as in teenagers or young adults. So it's not inconceivable that this is very much part of the progressional spectrum as the Chiari tends to develop over time. And there is some literature consensus that if you do a short follow-up, you're not going to find the progression or regression. If you do a medium follow-up, then you might find either radiological or clinical progression, and that becomes more evident. And in our group, we found that there was a subgroup that deteriorated rapidly within 2 years, mostly associated with loss of CSF flow at craniocervical junction or syringomyelia. So that kind of brings us to evaluate what is the pattern of progression and severity in Chiari. So we know the fate of the Chiari now. And do all Chiaris progress equally? No, of course not. So a simple Chiari, and we call a simple Chiari one that doesn't have ventriculomegaly, doesn't have craniosynostosis, there is no CSF signal loss at craniocervical junction, no craniocervical junction anomalies, syringomyelia, scoliosis, that is less likely to progress to surgery. And then it's the complex Chiaris where there is tonsillar herniation with syringomyelia, which is in 1/3 to 1/4 of patients. 2/3 to 1/3 to 3/4 of patients who develop a syrinx. And then those are the patients that we think are going to end up requiring intervention. And then, of course, the mechanism progression. There are several theories. Williams postulated craniospinal pressure dissociation as a cause of syringomyelia. Gardner suggested CSF pulse. I think the host had muted me. Can I continue?
Yes, yes.
Okay, so the pattern of progression and severity of Chiari, again, I think in multiple international surveys of surgeons, the majority of surgeons consider that you need to have a symptomatic Chiari. You need to have a tonsillar descent of at least 12 millimeters with loss of CSF at craniocervical junction and the appearance of a syrinx. Those would be the drivers for you to consider surgical treatment. And can a Chiari be treated by a foramen magnum decompression? And I think this is, of course, the gold standard treatment. Everybody undergoes a foramen magnum decompression. But in fact, data is suggesting that the complex Chiaris can be a formidable problem with significant morbidity. And these cases require careful planning and investigations prior to surgery. And really, surgery should be tailored to the causes of the Chiari rather than the Chiari itself. And as a result of that, in Birmingham, we started looking at something that could provide this versatility and reduce problems. So I would go ahead and say that Chiari malformation should really be termed deformation because, as you can see, there is no reason why it should be a malformation. There is an increase in the size, there is a change in the shape, and all of those are more characteristic of a deformation. So if we were to say that this is a deformation, then what are the pressures that are acting on worsening deformation over a period of time? And clearly, when we talk about a hernia, you have to think that there is increase in one compartment in relation to the second compartment. And this is what we call a supratentorial crowding. So here you have a patient who has got a small posterior fossa, hasn't got enough space for the contents of the posterior fossa, and the supratentorial compartment is crowding that space. So what happens is, over a period of time, the constant piston drive is going to lead to more crowding. That will then block the flow of CSF. You will definitely develop ventriculomegaly, and that then causes an additional push. So there is a mechanism here that we wanted to explore. And then I will show you some examples of how reversing those mechanisms actually causes the hernia to regress without foramen magnum decompression. The mechanism that I'm talking about is the development of ventriculomegaly, the skull-base anomalies, and the posterior fossa, small posterior fossa. We all know that the Chiari hindbrain hernia is associated with either ventriculomegaly, craniosynostosis, skull-based anomalies like basilar invagination, craniocervical junction instability, and scoliosis. And interestingly, these are the very same conditions that are associated with syringomyelia as well. But we also know that syringomyelia can be associated with tethered cord, spinal lipoma, split cord malformation without having a Chiari. So there are other conditions that can cause a syrinx rather than a Chiari in all cases. And then one thing that we discovered in Birmingham, and I'm sure that all of you have had experience with this, is the association of Chiari with growth hormone deficiency. Not just growth hormone, but other hormonal deficiencies like thyroid and so on. And in our study, what we found is that 40% of the patients with Chiari had growth hormone deficiency on treatment. 15% had clinical features of growth hormone deficiency with a short stature, which is idiopathic short stature. 20% had idiopathic short stature, but no growth hormone deficiency. And more than 20% were obese, but that probably is to do with the obesity and endemic in the UK. Now, when we turned the tables around and we looked at all the children with growth hormone deficiency and say, well, how many of these children had a Chiari? We found that only 1.2% of the children with growth hormone deficiency had a Chiari, suggesting that there is no significant hormonal effect on development of the Chiari, but the reverse deserves further study. When we look at ventriculomegaly as a mechanism associated with Chiari, again, is it the Chiari that causes the ventriculomegaly, or is it ventriculomegaly that worsens the herniation of the cerebellar tonsils? On one hand, of course, the presence of ventriculomegaly in supratentorial compartment will cause crowding. This will create a piston drive effect with downward displacement of cerebellar tonsils, or obliteration of the cisterns at the craniocervical junction, loss of buoyancy, and further descent and impaction of the tonsils. Or does the Chiari cause ventriculomegaly? So again, tonsillar descent to the foramen magnum can lead to blockage of CSF outflow, and that potentially blocks the foramen of Magendie and Luschka and development of ventriculomegaly. So all of that has been reported, and I suspect that both mechanisms are in effect with a sort of a catch-22 potentiating effect. And there is evidence that if you operate on these children and carry out endoscopic third ventriculostomy, that this results in a successful reversal of the Chiari. My colleagues from Rome, Professor De Rocco's team, as well as my friend from Liverpool, Conor Malucci, and his team had published evidence suggesting that if you carry this out, 94% will remain shunt-free following ETV for Chiari, so treating the hydrocephalus, and 83% with the syrinx, that improvement of resolution of the syrinx following an ETV. So there is good data suggesting that there is an association of ventriculomegaly with Chiari, and the treatment of ventriculomegaly also reverses the Chiari and syringomyelia. A further larger study came out from the Chinese group, again, talking about the association with the 80% success rate. So we did our own study in Birmingham, and we looked at our endoscopic third ventriculostomies, how many patients had Chiari, how many we intended to do an ETV for a Chiari, and we looked at long-term outcomes on this group. 130 patients, 139 ETVs, majority were older than 1 year. The commonest etiology was aqueductal stenosis and tumor, and primary etiology. So if you look here, aqueductal stenosis, tactile pineal tumors, other tumors, IVH, and Chiari and spinal bifida, 10 cases. That's 7% of the total number of patients that we operated. Now, this is many years ago. The number, of course, is increased, but the success rate has stayed the same. When we looked at ETV success, looking at ETV success score, it remains at 90%, and that compares favorably with all the other groups, except, of course, the tactile pineal tumors, which have been the most successful. So there is good evidence that in selected cases where there is ventriculomegaly or hydrocephalus with Chiari, that the ETV will reverse the hindbrain hernia and deflate the syrinx. And we're quite happy with that. So this is our series of patients showing 90% Chiari regression and 100% syrinx deflation on the patients that had a syrinx. So we also looked at factors associated with syringomyelia in children with chronic hindbrain hernia. So this is, I have to give thanks and credit to all of my colleagues, particularly a lot of the fellows that work with me. They, of course, moved on and gone elsewhere. And Paul Davis, who was our statistician, was quite instrumental in getting things right for us. So the factors associated with syringomyelia in children with chronic hindbrain hernia, of course, you know the pathogenesis. I'm not going to spend time there. You know the background, the percentages. But we looked at this MRI scan and we say, okay, what are the factors that we recognize here clinically? So on the MRI, if you look at this MRI, what we find is that the cerebellum is within a small posterior fossa. We can see how small the posterior fossa is. It is standing up, is no longer C-shaped. It's more like a standing up cerebellum. The tonsils are peg-like. It's got an effacement of CSF at the foramen magnum, a flattened occipital bone, a steep tentorium. See how steep the tentorium is? There's a lot of venous engorgement and a cervicomedullary kink. Because these patients also have a dolichoid dens, and we were just talking about Charles earlier, Charles Rebo, and he has also identified this as an association with Chiaris. I think we see it very, very frequently in our series. And these are the sort of features that we know are associated with the hindbrain hernia. And we know that in normal situation, this is the CSF distribution. And when you get a Chiari, that's what happens. Everything gets pushed forward and downwards. And this acute angle of the tent is typical of a small posterior fossa. And then you get the small, short, stubby clivus and the rising of the odontoid upwards with a posterior bend or indentation, creating a kink at the craniocervical junction. And you can see the odontoid kinking backwards here. You can see the small posterior fossa. And Menezes in 1991 showed that up to 50% of the patients with the Chiari had significant skull-base anomalies and craniocervical junction anomalies. You can see platybasia, basilar invagination. So these patients have this, they develop a syrinx. So we started putting all of this together, and we realized that there are some conditions. The commonest one, of course, is the Chiari association with syringomyelia, but craniocephalic mismatch, craniocervical junction compression, craniospinal pressure differential, like when you do frequent lumbar punctures or you have lumboperitoneal shunts, you draw too much CSF, you lose your CSF buoyancy, and you get a hindbrain hernia. So all of that, or restriction of spinal cord ascent, or rhomencephalon rotation, which is particularly the case with spina bifidas, or in the case of tethered cords, they will lead to formation of syringomyelia and may also be associated with the hindbrain hernia. So when I fill this, you can see that there's a number of conditions associated. And these are all the conditions that I have seen in my experience in Birmingham associated with the Chiari and syringomyelia. So nothing that is here is just from the books, it's from personal experience on our series. And when we looked at the statistics, what our statistician has told us, that syringomyelia is statistically associated with a larger surgical diameter of the foramen magnum, small posterior fossa, and acute clival, apical, and basal angles. Of course, we don't do this as much as we did before, because on the MRI, you can visually inspect these things. But if you measure these angles, there's a great statistical association, which we have identified. But of all of them, the loss of CSF signal at the foramen magnum was significantly associated with syringomyelia. So if you have a child aged 100 months, that's 8 years and 4 months, tonsillar hernia more than 12 millimeters, the ratio of the sagittal diameter more than 6.6, a clival angle of less than 0.8, then you're talking about a high chance of developing a syrinx. So here we get, now we get to the pathophysiology concept. Chiari and syrinx formation associated with a small posterior fossa volume. Chiari and syrinx formation is there supratentorial crowding. So we hypothesize that in some of these cases, there's an additional effect of supratentorial crowding that effectively reduces the functional infratentorial space. And in this discrete group of patients, it may be a major factor leading to tonsillar hernia or syringomyelia. So look at this case. Okay, this is a child with multiple suture craniosynostosis. You can see the copper-beaten appearance, the erosion of the skull. In the child like this, where the brain is pushing out, is like in a prison. There's no doubt that some of that brain is going to herniate through the foramen magnum. Another child, Klebat shadow deformity, MRI, age 2 months. You look at this, severe brachyturicephaly, and look at the size of the posterior fossa. There's no doubt that this child is going to have a Chiari, because that's the only place the brain can herniate now. So in these situations, nobody will doubt that the Chiari is caused by a craniocephalic mismatch. And you remember the definition of 5 millimeters. But if you look at the CSF on the normal case, and as the Chiari progresses, you can see that there is also a curvature, and the brainstem seems to be pushed forward and develops this appearance of a more severe Chiari, which I showed you before. So we know that there is some effect at the craniocervical junction and an effect on the brainstem. So if I can show this in a pictorial fashion, here's a normal situation. You can see the line from the posterior clinoid to the inion and the supratentorial line. Now, if you think about this, this is a child with a Chiari and another one with more severe Chiari. The first thing you notice is that a lot of the occipital lobe is now lying below that line. Because the posterior fossa is small, the angle of the tent is very acute, and the occipital lobe has no place to go here because there is flattening. The supratentorial space is crowded, so it pushes into the space that should have been reserved for the cerebellum. And this then causes a volumetric loss of space in the posterior fossa, pushing the rest of the posterior fossa contents into the spine through the foramen magnum. So this reduction comes from the supratentorial crowding, because that occipital lobe should not be below or behind the cerebellum, should be above. And here, the line that crosses between the posterior clinoid and the inion clearly shows the significant loss of volume, which has been occupied by the supratentorial compartment, or what we call supratentorial crowding. And that then causes the bending and the cervicomedullary junction compression, and leading to what we call a foramen magnum syndrome. So all of this can be evaluated through radiological measurements. And we carried out a lot of these measurements. And what we found is that in a Chiari 1 and Chiari 2, the sagittal diameter of the foramen magnum, as we expected, is incompetent, is much bigger than a normal foramen magnum. And you need that. If you want to get a hernia, you need an incompetent hernial orifice. So the foramen magnum in both the transverse diameter and the sagittal diameter is bigger than a normal patient. And the surface area is significantly larger as well. So we know that there's an incompetent orifice. The foramen magnum is bigger, both in Chiari 1 and Chiari 2. And then the surgery that we are performing is actually making that orifice even bigger. So it makes absolutely no sense that you carry out this sort of treatment in a Chiari. And then when we looked at the associations, we can very clearly say that there are supratentorial, posterior fossa, foramen magnum, and spinal associations. And we then started looking at this and targeting those associations in an attempt to reverse the Chiari, rather than just make the foramen magnum bigger when the opening is already big. So here it is, Chiari 1 and Chiari 2. Increase in the intracranial contents, small relative cranium, presence of incompetent orifice, and the syrinx as what we would call a strangulated hernia. There are also, this is a summary of the skull-based lesions. I'm getting an echo. Are you guys all right? So in terms of embryology, the only thing you need to remember is that the skull-based anomalies occur only with the occipital somite 4, or what we call the pre-atlas, and that leads to most of the abnormalities associated with Chiari. So that's the only thing you need to remember. So to keep it simple, somites 1 and 2 and the others are not as important for Chiaris. It's the pro-atlas. And the atlas assimilation is one of the commonest associations I've seen in my experience. And that usually means fusion of C1 with occiput and fusion of C2, C3, usually posterior elements, increasing the atlantoaxial subluxation and the association with the Chiari. And of course, there's 3 groups which can occur. We also know about instabilities. I'm not going to spend too much time here. Suffice it to remember that instability can be horizontal, vertical, which is basilar invagination, lateral or rotatory. So all of this can be associated with the Chiari. And Professor Goel, I remember mentioning it to me that atlantoaxial dislocation instability is the primary cause of all types of basilar invagination, and irrespective of whether it's demonstrated or not on dynamic imaging. Now, if you think about basilar invagination, how does basilar invagination actually occur? So this is a diagram to show what happens. So initially, that's posterior arch of C1, this is C2. The first thing that happens is the atlantodense interval increases. At this point, you can diagnose this radiologically and say this is horizontal subluxation. But as time goes by and the lateral masses of C1 separate from each other, more of C2 rises up through the arch of C1. When that happens, the atlantodense interval actually becomes smaller. And the atlantodense subluxation disappears. And you start thinking that there is an improvement on the patient. But actually, the instability has got worse because it's no longer horizontal, it's also vertical. And this is associated with the separation of the lateral masses. So if you think about the normal angle, which is about 125 degrees, you can see the occipital condyles are at an angle, but the C1, C2 condyles, the lateral masses, are horizontal. And in basilar invagination, the horizontal lateral mass of C1 and C2 start becoming oblique and ultimately become vertical. And this is how C2 then rises up because the lateral mass of C1 have to slide down on oblique lateral masses. And we can see this on this diagram again. There is widening of the lateral mass of C1. C2 rises up. And here you can see the foramen magnum line. The dens is now gone through the foramen magnum. And this is because the lateral mass of C1 and C2 are no longer in horizontal fashion. They are nearly vertical. And this is exactly what happens this is an example of a patient. You can see the lateral mass of C1 here, lateral mass of C2. This patient has a vertical alignment. And this is how basilar invagination happens. Goel has further classified them as group A and group B. Group A, when they go through the Macrae's line or the foramen magnum line. Group B, just below that. You can see assimilation of atlas in this patient. Usually they have fusion of C2, C3, and further subluxation. He's also talked about central invagination and facets, the contribution of facets to basilar invagination. You can see the facets here anteriorly dislocated, posteriorly dislocated, and then central dislocation. So here's an example of basilar invagination with herniation of C2. So all of those cases can be associated with the Chiari and syringomyelia, and the treatment really requires us to correct them. So this is a child that presented, with the typical appearance of snoring, falling behind in school, and then the child deteriorated, became myelopathic, came to see me. I had already operated on this child because the child had Crouzons and had a posterior, cranial surgery for correction of that. So I was quite surprised to see that the child had presented with this. And looking at the radiology, you can see the typical description I just gave you of a basilar invagination progressing. You can see the tip of odontoid now through the foramen magnum, the oblique or nearly vertical alignment of lateral muscle C1 and C2. So all of this are typical appearances in these patients. And then what we do is distract C1, C2, pulling C2 down from C1. This is a technique described by Atul Goel. And then after distraction, we screw, I did an occipital cervical fixation on this child. You can see the C1 screws, C2 screws. And then once the C2 is brought down, this is pre-op, this is post-op, and do the fixation. And you can see the pre-op appearance and the post-op appearance on this child. So clearly, this is the sort of thing that could not be improved. In fact, would be worse if you had just carried out a foramen magnum decompression to create space at the foramen magnum. So the mechanics of this progression, therefore, can be put in an algorithm. And this is the algorithm that I wanted to present to you. So you can see here, I'm just going to put the whole thing because it is quite a heavy slide. But if a patient has ventriculomegaly, there will be raised ICP, supratentorial crowding. Patients with craniosynostosis will have raised intracranial pressure, small posterior fossa, craniocephalic mismatch, supratentorial crowding. And all of that will stretch the tissues through the foramen magnum and lead to Chiari. The ventriculomegaly does the same thing by a downward push and Chiari. And of course, once the Chiari is strangulated the foramen magnum, a syrinx will develop. This is basilar invagination craniocervical junction anomaly. Will be associated with the small posterior fossa, craniocephalic mismatch, will push tissues through Chiari syringomyelia. And of course, then the separate pathway, which is the caudal pool, where a lipoma or split cord malformations, tethered cords, can lead to scoliosis and syringomyelia without a Chiari. So this is the pathological algorithm. And how do we reverse it? By treating each one of those separately. And that's what we've been doing. Now, this is against the current standard, which is the craniovertebral decompression, where you either open the foramen magnum without the dural opening, or then do it with the arachnoid opening, or in addition to that, a tonsillar resection with the duroplasty, no duroplasty. So there are a multitude of different ways of doing a foramen magnum decompression. But what we know is the majority of the complications of decompression surgery have to do with opening the dura, too large a posterior fossa decompression, too extensive resection of C1, C2. Those are the things that we worry about the foramen magnum decompression. And we also know the complications of the dural opening, which, I don't have to read the list to you, you're familiar with it. And a multiple series of publications are now attesting that if you do a foramen magnum decompression, in something like 5 years, 2/3 of the patients will come back with symptomatology and may require further treatment. And further treatment means further surgery. And Claire Clamp, who has done quite a lot of work on this, cautions people about further revisional surgery because the long-term success for foramen magnum revisions is quite limited. And what you do then when you have done 2 operations on these patients? Colleagues from Oxford have reported on recurrent subdural hygromas after foramen magnum decompressions. They're, of course, not the only team reporting abnormalities. Conor Malucci and his team have reported raised intracranial pressure and development of hydrocephalus following decompression for Chiari 1. That means these patients didn't have hydrocephalus, developed hydrocephalus after a Chiari decompression, resulting in a need for permanent VP shunt in that series. Another study from Ireland, foramen magnum decompression for Chiari, procedure not to be underestimated, talks about nearly 54 foramen magnum decompressions with significant complications, including one death and development again of hydrocephalus. So 18.5% of their patients required shunting after foramen magnum decompression. So when we look at posterior fossa decompressions with or without duroplasty, again, there's a greater risk of CSF leaks associated with posterior fossa decompressions, and if you open the tumor, of course. So in 2009, we published our experience with posterior calvareal vault expansion using distraction osteogenesis. So this is the Birmingham series. This was the first publication. Of course, we have done nearly 100 of these cases and about 50 fixed augmentations. So this is what we call dynamic osteogenic distraction. You can see the majority of the patients were craniofacial patients. And you can see here the typical copper beaten appearance. What we do is we make a cut like this, and then using telescopic distractors, we gradually distract the skull to reverse the craniocephalic mismatch, which all craniofacial or craniosynostotic patients have. The distraction is very slow, something like 0.5 millimeter in the morning, 0.5 millimeter in the evening, so about 1 millimeter a day for 20, 21 days, 23 days, depending on the, the pathology. And what that does is results in decompression or decrease in the compression of the brain and reversal or regression of the hindbrain hernia. This is an example of a child with Crouzons with improvement of the Chiari. There's multiple publications appearing with similar examples. This is one from Liverpool. This is from Richard Ellenbogen and his team in the States, stating that the resolution of syndromic craniosynostosis associated Chiari malformation without suboccipital decompression after a posterior cranial vault release. So once we presented our data, a number of units started performing the same procedure. I won't go into all of the papers, but this is the paper from Finland. They've got a similar experience. This is the one from Paris, the posterior cranial vault distraction, efficacious technique to enlarge a posterior skull and treat ICP. Moreover, it appears to be efficacious in treating hindbrain hernia-related symptoms. We were able to show that it not only helps patients with craniofacial craniocephalic mismatch, but also patients without craniosynostosis, but craniocephalic mismatch. So this is a normal appearance. This is a patient with syndromic pansynostosis. What are the changes that occur when you do a calvareal augmentation or a calvareal distraction? So the first thing, of course, that you see is that this is the difference. These patients have a mismatch, constricted brain growth, because their skulls are not a normal shape. And to accommodate for that, they get a bit of thoracephaly. It's a compensatory phenomenon. The ventricles become squashed, as you can see here. And then after this, because there is no space here, the brain grows in an abnormal direction and they get frontal bossing. So this is quite typical. Everybody understands that. The aim is to recreate the normal shape and expand the posterior skull by doing this. If you do ICP measurements on these patients, when you do the surgery, you can see that there is significant pressure waves, diploic vessels causing collateral circulation as a result of venous hypertension. Once you do the calvareal augmentation, the pressure drops significantly. So we know that calvareal augmentation is very effective in dropping the pressure. And in Birmingham, we started doing a posterior skull release from 1984 to 2003, posterior augmentations from 2003 to 2006. And since then, we've been doing distractions. And that's the technique of this is very straightforward. We make melon slice cuts in the posterior parietal region to the occipital region. Before, we used to go all the way to the foramen magnum, but now you can do this above the torcular, which is safer. A piece of bone is cut and then is pushed back, and fixed metal or resolvable plates are then applied to secure the bone so it doesn't move forward. So this is a fixed augmentation technique. That's occipital alone. You can also do it with parietal expansion. You can see the parietal bones are barrel staved and they're pushed back together. And this is a surgical appearance of that. This is a shunt here. So you preserve some bone around the shunt. The scalp is reflected as standard. That's the frontal area. This is the occipital area. So we have reflected the scalp, the patient's in a prone position, and then basically these are the cuts that we do. This is the occipital bone, the two parietal plates. This is the bone that we kept for the shunt. The central part, which is compresses the posterior sagittal sinus, is then removed, and then everything is put back, as you can see here. That the appearance. I've got a series of patients. I won't spend too much time here because I just want to take you to the conclusions now. This is a study we carried out that looked at the effect of posterior calvary augmentation. And what we were able to see is that the infratentorial compartment increased, but not as much as supratentorial compartment. We published that in our paper, which is here. And as you can see here, this is the distraction part. This is how the bone is distracted gradually. Post-op appearance, this is pre-op. You can see how the skull was very flat, small posterior fossa. And then after distraction, with an angle of about 5 millimeters, this was the initial distractor that we used, pre-op, post-op. And that's all that is necessary to reduce the hernia, the serrings, and bring about a reduction in the intracranial pressure. So these are the pictures of patients who had this. You can see the brachiothoricophaly, distraction. And we then looked at our 10-year experience in these patients with cranial synostosis and Chiari and syringomyelia. And we were able to confirm that these patients had shown improvement in 75% of the patients with the serrings, 3 out of 4 patients with serrings, and they are similar in Chiaris. And then the final one that I want to show you was the Sacral Myelomeningocele cord tethering. So you can see here, this is a child who's got sacral, tethered cord right into the sacrum. You can see the cord coming down and a hollow cord serrings associated with that, and no Chiari. So what we did is we carried out a untethering of the spinal cord and postoperatively resolution of the serrings. So before, you can see no Chiari, hollow cord serrings, untethering of the spinal cord, deflation of the serrings. So we know that there is an association of a caudal pull where you get a tethered cord and the tethered cord stretches the serrings and causes syringomyelia, and that can cause scoliosis as well. And that leads to the formation of the serrings. Now, the final example I wanted to show you, and then I'll stop and give you some conclusions, is patients who had the Chiari and serrings and had craniovertebral decompressions, and then because of the multiple failures, they offered calvary augmentation. So this is one example. In 2014, pre-op image, Chiari and cervicothoracic serrings. You can see the Chiari, you can see the serrings. The patient was advised foramen magnum decompression, which the patient underwent. You can see the formation of a cisterna magna. The surgery appeared to be adequate, but in fact, the serrings never got any better. You can see that there is hardly any CSF flow in the craniocervical junction, because the moment the surgery happened, there was further herniation of the cerebellum or the brainstem into that space. The patient was further reviewed. They started developing scoliosis. There was further discussion about what should be done. By 2016, the child started getting more problems. You can see that the cisterna magna is still patent, and it's always suggested that if you do foramen magnum decompression, you should have a cisterna magna development. So underwent a second craniovertebral decompression. Now you can see very little CSF there. The serrings have now become nearly pseudo-bulbar serrings. The patient didn't get any better. Further progression. And then I was asked to do a calvary augmentation in this child, which I did. And in 2018, within 3 months of the surgery, the serrings deflated, the Chiari regressed. So I think we can say that the pathology of a Chiari is the most crucial thing in the success of its treatment. And if you do one operation like a one-trick pony for all Chiaris, you're bound to have some failures. And adequate selection is what is important. So this is why we created this algorithm. So if you have ventriculomegaly with raising the corneal pressure, supratentorial crowding, causing that, what we would suggest is for ventriculomegaly, do an ETV. If it is successful, monitor. If it is not successful, then consider posterior calvarial augmentation. If you have got cranial synostosis, definitely a posterior calvarial augmentation or distraction. If you have scoliosis requiring correction, then what we suggest is carry out the posterior calvarial augmentation first and then observe, because about 1/3 to 2/3 of the patients have had improvement in the scoliosis after the regression of the Chiari and did not require scoliosis correction afterwards. And if you got basilar evagination or craniocephalic junction instability, then a fixation should be carried out first rather than foramen magnum decompression or posterior calvarial augmentation, which can be resolved subsequently should it fail. And for the patients who have split cord malformation, I think an untethering and observation should improve the syrinx. That's the algorithm we've developed. And so far, this algorithm has proven successful in our experience, but of course, we're waiting for long-term results. So this is, bit by bit, is the same thing. And what I'm going to stop here because of the time, and I'll leave for questions from you guys. Thank you very much.
Thank you, Girish, for this nice presentation. Wonderful experience. And any comments from Bello or Moody?
Yeah, thank you very much, Girish. That's really, I have to say, an eye-opener, literally, because a lot of information and a lot of shifting paradigms here. And I congratulate you for the amount of information and the amount of work that you've put into this, and really it's groundbreaking stuff, as we've seen. In my mind, the summary seems to be that the problem appears to be at the craniovertebral junction. I mean, seems to be seen at the craniovertebral junction, but the cause is either a tethered cord or the cord itself pulling the structures down, or the cerebral cortex being, again, the intracranial contents pushing the structures towards the foramen magnum. And you've obviously illustrated beautifully the augmentation, cranial augmentation that you've done in syndromic patients. And the question that comes to my mind is whether in the non-syndromic patients, one could move or push the envelope and say, rather than targeting the craniovertebral junction, target the posterior or the occipital bone itself, and through scalp expansion, primarily first have enough skin, and then actually use a 3D formatted bone structured cranioplasty implant, as it were, in older patients. I'm not talking about the syndromic ones. The syndromic ones you've obviously described beautifully, but in the non-syndromic ones, where you can see the cerebellum being pushed down by the structures in the supratentorial compartment, is there in your mind a solution sitting there to be had by expanding that posterior or the occipital region and decompressing it, almost like what one does for a decompressive craniectomy in head trauma, for example? Not suggesting that's what we should do, but recreating that or remodeling that posterior cranium for room to be created, and therefore the pressure taken away from the cranial cervical junction. I'm just thinking aloud, I'm sure, but I wonder what your thoughts are.
No, absolutely. It's a brilliant thought. And I have to say that others have thought about this. And in fact, when my first operation, because this thing was, as you can imagine, this is not the sort of thing that you can just go and do overnight, because they would be immediately called a cowboy and they would stop you from operating. And that nearly happened to me anyway. But others before me had thought similar thoughts. And the most notable one is actually Atul Goel. He published many years ago his experience with occipital craniotomy for Chiari. So what he did, because he had also noticed, as a visionary that he is, he had also noticed that the occipital somite, the occipital bone is small and is concave. So what he did is he would cut do occipital craniotomy, turn it around, make it concave, convex on the outside, and would then plate it or suture it. And he did a number of these cases, and he then published his experience. So I was quite excited by, that somebody had done something like this, because as you can see, the pathophysiology is that this is caused by a small posterior fossa. At least in children, we have no doubt about that. So I did a few of these cases, but the results were mixed. So some of the cases, at least one got better. Actually that patient, I had completely forgotten about. And I only remembered because she got pregnant and she was going to have a baby. And because I plated the augmentation, they contacted me and they said that she's got plates in the brain. Can you tell us what it is so that we can carry out an MRI scan? So this is how I found out that this patient had, had operated on an occipital, had done occipital craniotomy. And a syrinx had disappeared and the Chiari is regressed. So there is no doubt that this is something that people have tried before as an augmentation procedure. Of course, you'll be aware that some of the, one of the things that are being done now is using ultrasound. You can do a foramen magnum decompression without dural opening to create space, in a posterior fossa. But the idea of what you suggested, it's doable with the technology we have today. But I would have thought that you probably don't have to do, an artificial cranioplasty for this. You can use 3D modeling to plan your surgery and then carry out the surgery in a way that provides a better outcome by shaping the augmentation more accurately. If I read your thoughts properly, is that what you meant?
Yes. I was thinking of a quick fix, I suppose, but yeah, if you were to do 3D reconstructions and then create through whatever mathematical models to recreate that space, and then perhaps not use artificial, but use split bone to basically recreate your extra space in the occipital region. And again, I'm talking about the non-syndromic ones. That's what I was thinking.
No, absolutely. So to be honest, in the pediatric Chiaris, and we have operated on some adult teams with nearly adults with equally successful results. The bone is very thick. So if you're talking about adults, the bone thickness is enormous. It's more than 2 centimeters in thickness at the back.
Right.
So one thing that you can easily do without actually having to pull the skull back is to take out the inner cortex and the diploe of the bone posteriorly, and you can augment the volume of the skull by about a centimeter to centimeter and a half by that simple procedure. It's tedious, it takes a very long time, but I've done that as well. So you can just reduce the thickness of the skull, and by doing that, you increase the volume of the skull. So that certainly is something patients who have G6 phosphate deficiency, sickle cell disease, all of those patients which have a significant increase in the diploic marrow, they have very thick bone, and you can treat this by just shaving off the skull thickness, and they get an improvement in the craniocephalic mismatch.
Thank you very much. Amazing thoughts, really very educational, and as I said, paradigm shifting. Thank you. It's really been a pleasure listening to that talk. Over to you, Bedo, Mohammed, and the other panelists, please.
Yeah, thank you, Girish. And now I will pass it to Llewellyn Yeah.
Thanks, Mo, and thanks, Girish. That was an absolute masterclass. And I know if I were to ask, maybe quickly, Bello, any comments you want to make? Just some quick comments.
To thank Gurish once more. Nice hearing you again.
Okay.
It's
excellent. Thanks, Bello. Thanks for being so cognizant of time. And I know Graham's got a whole lot of comments similar to some of mine. I'm going to make a quick comment, Girish. I mean, you've just developed so much insight into this condition. It's really ridiculous how sort of educational that talk was. Just 2 points. I know you flagged the value of ventriculomegaly, but ICP rather than ventriculomegaly. When I say measuring ICP, I don't just mean raised intracranial pressure, but intracranial hypotension, because that can cause slumping of the cerebellar tonsils. So that might be something to just work into. Not as a sort of discussion point, but you know, just as a comment, maybe if we get some time at the end, we can flush through that. And I gather Graham would have some comments, like I said, but in the interest of time, we're going to move on. So I'm going to introduce our next speaker. And in this sort of paradigm of not really congenital, but you know, developmental malformations or deformities of the spinal canal, we've invited Graham Fegan to talk to us about open spinal dysraphisms, and in the African context, probably more myelomeningocele. So it's a great personal pleasure of mine to introduce Graham Fegan. So Professor Graham Fegan is the Helen and Morris Morberger Chair and Head of the Division of Neurosurgery at the University of Cape Town and Groote Hospital, and really, to my knowledge, is the only endowed chair of neurosurgery on the continent. He also serves as director of the UCT Neuroscience Institute, and is currently the head of the Department of Surgery, which is quite a prestigious appointment, a rotating appointment where one of the neurosurgical disciplines runs the entire department. His interests include functional and pediatric neurosurgery, and he's played a phenomenal role in the development of neurosurgery educationally and sort of, you know, the advancement of neurosurgical awareness in Africa. He's held various leadership positions, including president of the Continental Association of African Neurosurgical Societies, so CAANS, the association that we have the privilege of presenting these talks under. He's been previous president of the ISPN and the Society of the Society of Neurosurgeons of South Africa, of which he's still current president. So Graham is widely recognized as a leading international figure in pediatric neurosurgery. And like I said, it's a true personal privilege and pleasure for me to introduce Graham to give our next talk. Graham, if you want to load your talk, please.
Right, hi, Llewellyn, thank you very much. That was really a wonderful introduction. But I guess of all the things you mentioned there, the thing that I love most is just being a pediatric neurosurgeon. So it's really a privilege to be part of this this wonderful webinar. But I guess before I start, I really would like to just pay tribute to a very dear colleague that Bello mentioned at the start. We lost our dear friend and beloved colleague, Professor Suad Bhakti, who was really, to my mind, one of the really great African neurosurgical leaders. I got to know Suad 10 years ago when we started CAANS. She attended all the CAANS meetings. Was really a very, very powerful influence in the creation of CAANS, and truly believed in African neurosurgery. And certainly for the younger neurosurgeons joining this webinar, I could think of nobody who is a finer role model than Suad. She just truly believed in neurosurgery and was not a political person who was advancing her own career. She really tried to advance education and care of patients. And probably the warmest memories I have of Suad were going to Algeria for the first CAANS meeting that she helped to organize. And it really was an incredible privilege to go to Algeria. And I just want to extend a special word of condolence to our colleagues in Algeria. I can't imagine how terrible the loss is. So my task this evening is to just give you few thoughts about open spina bifida. And when I'm done, you're going to hear all about closed dysraphism from my dear friend Sandeep Chatterjee. So I'll try not to take too much of your time because I'm sure Sandeep has a lot to share with you. Just to make the point that as neurosurgeons in Africa, the future is really about the children. And Africa's population is growing very rapidly, and it's a great time to be a pediatric neurosurgeon in Africa. But the reality is that the majority of children in Africa, in fact, in most developing countries, are not operated on by neurosurgeons or even general surgeons. And oftentimes it's just medical practitioners or even clinical officers that treat children, especially kids who are born with spina bifida, who often need urgent treatment, and there isn't really time or facilities to refer them. Another thing just remember is that the clinical assessment is really important in little children. The default finding is claiming that kids are normal, and oftentimes when you go back and examine them more carefully, you find there is a deficit. So just be careful in your clinical assessment. Think twice about imaging. CT scans are not great on a cumulative basis, and often kids with spina bifida with shunts end up with getting a whole bunch of CT scans, and you really want to be cautious about how often you scan them. And remember, when you're operating on a small baby, you've got many, many years of life ahead, and always take development into consideration. So open spina bifida or myelomeningocele, we typically refer to as dysraphism in neurosurgery. And as you all know, dysraphism either happens at the top end or the bottom end. And my task now is to talk a little bit about open spinal dysraphism or myelomeningocele. So as you know, what you see with myelomeningocele is, oops, sorry, just got my slides are jammed. Yeah, what you see with myelomeningocele, and that's a typical picture of a newborn baby with an open lesion on the back. What you see on the back is really just the tip of the iceberg, and a large part of the problem relates to what's happening more rostrally, particularly the Chiari Malformation and Hydrocephalus. And I'll talk about that in a few minutes. It's an ancient disease, and one of the complicating aspects of spina bifida is the fact that there's so many different terms to describe spina bifida. And probably the reason for that is it's one of the few neurosurgical conditions that presents on the outside and has obviously been known for many, many centuries. And another distinguished colleague who we lost last year, Jim Goodrich, has written a great deal about this. And anyone's interested in the history of spina bifida, I can commend you to Jim's writings on this. But what's interesting about spina bifida, it's not just a boring old condition that we figured out. In fact, if you look at the literature, there's been a massive resurgence of interest in spina bifida in the last couple of decades. And I think that's largely due to the recent advent of fetal surgery, or probably more accurately described as maternal fetal surgery, because it's one of the few situations where you've got two patients on the table, not just one. But in fact, the more recent kind of 20th century history of spina bifida is very interesting in terms of the very radically differing paradigms of treatment that have been advocated. Prior to the 1950s and the advent of shunts, survival was pathetic. Fewer than 10% of newborn babies with spina bifida survived. When shunts came along, survival improved dramatically. We then had the phase of so-called selective treatment, or really in reality, selective euthanasia of children with spina bifida in the 1970s. And that culminated in what was called the Groningen Protocol in the 1990s, that advocated for kind of active euthanasia of newborn babies with spina bifida. The difficulty of that is that even though the vast majority of these children do have significant motor and often sphincter involvement, a very significant percentage of them are intellectually normal and are able to lead a very meaningful life. And the Groningen Protocol has since been discredited. In fact, there was an article in The Lancet a couple of months ago looking at the notion of our values in the decisions we make around the treatment of spina bifida. And I'd suggest that anybody interested in this topic has a look at that. Okay, so the challenges in managing myelomeningocele, firstly, making the diagnosis early, offering genetic counseling, the possibility of fetal surgery, which in Africa is not really an option. I was involved with Llewellyn in fetal case in Johannesburg 2 years ago, but I don't think this is the future of myelomeningocele treatment in Africa. We've got far bigger challenges we need to deal with. And then once the baby's born, how you're going to manage the newborn, the technique of your early closure, managing hydrocephalus, then dealing with late deterioration, the transition of care into adolescence. But probably most importantly of all, the fact that we can prevent these lesions in the majority of cases. So antenatal diagnosis, I'm not going to say much about other than to really strongly encourage all the neurosurgeons in this webinar to just get to know your obstetricians and encourage them to include you in antenatal counseling of women who diagnose as having a baby, a fetus with spina bifida. It's amazing how much we as neurosurgeons can add to the discussion and can really help in a very difficult situation, help parents make informed and appropriate decisions, whether to terminate a pregnancy or to continue with the pregnancy. And then if they do continue the pregnancy, at least to help them to make decisions on how to manage the baby after birth. And remember, genetic counseling is really important. And in many countries in the world, genetic counseling is now a very key part of the whole maternal fetal management team. So once the baby is born, and if your country is anything like South Africa, more often than not, these babies are born not without an antenatal diagnosis. So they kind of arrive from the labor ward and you get a phone call when the baby is born with an undiagnosed myelomeningocele. It's important to advise on the initial management, which is to cover the lesion, take care of the ABCs, particularly if there's any bulbar dysfunction, make sure that baby's breathing fine. But interestingly, other major anomalies are incredibly unusual actually in these babies with myelomeningocele. You then prepare the baby for surgery, and starting breastfeeding is really important. We do not advocate starting prophylactic antibiotics. The antimicrobial treatment of spina bifida is to keep the lesion clean and prevent it getting infected. You can take a swab, but really the most important thing is to close the lesion within 24 to 36 hours. There's a bewildering array of appearances of myelomeningocele, but the basic pathology is pretty much the same in all of them. And the operation is really actually very simple. This is not a complicated operation as long as you get the basics right. And for me, the simple, most important basic thing is to get the dura closed. If you get the dura closed, you literally and figuratively are home and dry, almost always. So these are the principles that I learned from my mentor, Jonathan Peter, many years ago when I was a registrar. Small babies, you want a warm operating theatre, a neurosurgeon who knows what they're doing, ideally with an assistant. Position the baby prone on bolsters, make sure the abdomen's free. Take care you don't damage the placode with your skin prep. You can use the loop, which I tend to prefer, or microscope. Intraoperative neurophysiology is really not necessary. There are some people who advocate for that, but I think it's really, in an African context, almost unthinkable to use intraoperative neurophysiology, although it's incredibly valuable in dealing with closed dysraphism, as you'll hear just now. And then in terms of your closure, it's really about getting the best anatomical closure. And I don't think there are any hard and fast rules about that. It's whatever's going to work anatomically. Be gentle with the tissue, be cautious and very, very judicious in your use of bipolar. Try to get at least 3 layers, ideally 4, maybe even 5 layers. But as I said, the most important aspect is getting watertight dural closure tested with a Valsalva. Never ever close the skin under tension, and then make sure you're giving decent post-operative analgesia. In an African setting, though, very often these babies don't pitch up for early surgery, and they come later when the placode is epithelialized. And sometimes as a neurosurgeon, you'll be faced with the ethical decision whether, in fact, to close the lesion or not. And in fact, the older I get, the more convinced I am that the best strategy is really to close the back initially and then try and be clever later. If you try and predict which babies are going to die early and not require surgery, the chances are the baby is going to survive, the lesion gets infected, and then you just have a much worse situation. So I really do believe the best strategy is to close the back early. And then you're in for long innings. In fact, probably many decades. And if you get it right, many decades of very good quality of life. I'm not going to go through all these different aspects of management, but it's really important to establish a multidisciplinary clinic with other colleagues. We've had a multidisciplinary spina bifida clinic in Cape Town since the 1950s, and we've described our experience, our management in the South African Medical Journal. You can access this article free, and it just describes how we go about managing these kids. I want to say a few words about some of the neurosurgical aspects. So hydrocephalus obviously is a really important aspect of our management as neurosurgeons. Almost always, if the baby does have hydrocephalus, it progresses, you're going to need to put in a shunt. ETV, given the anatomical abnormalities, can be a technical challenge. And as pretty much everybody in this webinar knows, there's very compelling experience from Uganda describing the use of CPC as an adjunct to ETV. So that's certainly an option to also consider. Chiari 2 malformations. You just heard a magisterial overview of Chiari 1 malformations from Girish. Chiari 2 malformations are not tonsillar herniation, but a vermian malformation. The reality is that almost always Chiari malformations are found in these kids, but they virtually never require surgery. But I wanted to show one case just to underline the fact that doing posterior decompression for Chiari 2 malformations may still be required. So this is a young baby that presented to my colleague Nico Enslin with worsening bulbar palsy. In fact, the kid ended up ventilated in the ICU despite a functioning shunt. And we had really good evidence that, in fact, the problem here was the Chiari malformation. So Nico took the child to theatre, and remember, please, please, please don't ever make the mistake of thinking that the posterior decompression here is a posterior fossa decompression. In fact, a posterior decompression in this setting is a cervical laminectomy. Don't ever try and open the posterior fossa because the torcular is very low and you're going to end up in a venous nightmare if you try and open the posterior fossa dura. And essentially what Nico's done here is he's done a cervical laminectomy, opened the dura, found a whole lot of arachnoid adhesions here, which is opened into the foramen of Mogendi. And this child actually showed a dramatic resolution of the clinical problem post-operatively. And the post-op CT scan showed resolution of the syringobulbar. So it's a really good operation to do in the right setting. So when you have a baby with myelomeningocele that you've operated on who deteriorates, there are a bunch of different options. Could either be shunt malfunction, could be a urinary tract infection, could be the Chiari malformation, syringomyelia, as you've heard from Girish, secondary tethering, scoliosis, even latex allergy. But in fact, in reality, it's either shunt malformation or shunt malformation or shunt malformation, maybe shunt malformation, once again, shunt malformation, and then you can actually start thinking about the other things. Almost always when these kids deteriorate, it's a shunt. Why is it worth putting such effort in? Well, probably the gold standard is a series from Chicago. And just remember, 2/3 of these kids actually can have normal schooling and can go on to actually have normal jobs and a normal quality of life. So it's really a battle worth engaging in to actually treat these kids properly. For those of you who are familiar with the ISBN guide, the ISBN guide is a fabulous resource to pediatric neurosurgery, and there's some fantastic background information you can refer to on myelomeningocele. Just to mention fetal surgery, as I say, we've been involved in one case on African soil. I'm not sure there've been any other cases done, and I'm really not sure that this is where we should be making our sort of biggest efforts. It is an interesting topic, and as I've said, probably the single biggest reason why myelomeningocele has had a resurgence of interest as a research topic in the last couple of decades. But I think there are other areas we can make contribution in Africa. Just if you are going to think about fetal surgery, though, make sure you get the diagnosis right. So here's a little guy who's referred to me, 21 weeks of age. The family were seeking fetal surgery. In fact, had been turned down by a fetal surgery program in the US. And it was clear when the baby was born, the baby had a skin-covered lesion. And you certainly don't want to be doing fetal surgery for this. I'm going to say just a couple of words about the embryology because it's just important in terms of setting the stage for prevention. So a couple of slides from Lee Niswander, who's a molecular biologist who's done a lot of work in this area. Neural tube closure is really complicated, and Andrew Kopp, who's an embryologist working in London, has done an awful lot of work in this over the last couple of decades, trying to elucidate the mechanisms that play a role in neural tube closure. The bottom line is it's a really complex three-dimensional process, and this video from Lee Niswander just shows that this is a complex process, and anybody who thinks that there's one gene that's responsible is clearly kind of barking up the wrong tree. There are many, many different genes that have been incriminated. The most important thing, when all is said and done, is that folic acid, which is a really easily available vitamin, plays a massive role. And we don't really know how folate works. We know it's involved in DNA synthesis. You come up with all sorts of different theories as to the role that folate plays. But the bottom line is you've got to have folate on board. By the time conception happens, the soon-to-be pregnant woman has got to have folic acid on board, and then you reduce the incidence of spina bifida by over 70%. So what goes wrong? And it's a fascinating interplay of a genetic predetermining predisposition. So a bunch of different variants, either coding or non-coding variants or other structural variants in genes, together with an environmental factor in your folate levels. I'm not going to go through this in detail, but a really lovely review from a group in San Diego, kind of explaining in detail this beautiful interplay between your genetic predisposition and folic acid, and in trying to unpack that complex interplay, to understand the fact that different people with different genetic predispositions will have different thresholds for disease. And even in the situation which all of you, I'm sure, will have encountered of women who have been taking folic acid and are really distressed by the fact that they've had a baby with spina bifida, to reassure them that in fact, probably by taking folic acid, they have reduced the severity of the spina bifida in their particular situation. So South Africa, we've had really progressive legislation with folate fortification. And in every single country in the world where folic acid has been introduced as a dietary supplement, there's been a reduction in the incidence of spina bifida. The Food Fortification International Group have a fantastic website where they keep track of all the different countries around the world and what they've done. And it's just fundamentally important for all of us as neurosurgeons to be banging on the doors of our departments of health, if they haven't introduced food fortification, to get them to do this. Just a little interesting aside, in the Tigray region of Ethiopia a couple of years ago, a massive increase in the number of babies born with spina bifida was reported. And this hasn't yet been figured out. But it is really fascinating how in different parts of the world, the incidence of spina bifida is very, very different. And clearly this, once again, is interplay of the genetic predisposition of different populations and varying levels of folic acid. So to end off with, I just want to kind of thump the drum here for our role as advocates for our patients, and to advocate for governments actually passing legislation that will reduce the number of babies born with spina bifida through food fortification. The ISPN has recently taken up the cause, and a few of us put together, including Sandip, put together essentially a mission statement that we're really pledging to work with governments around the world to make sure that we reduce the number of children born with spina bifida. But it is complicated, and every single neurosurgeon sees patients and prescribes valproic acid on an almost daily basis. Remember that sometimes the drugs we use actually play a role. And this is a heartbreaking case I had a few years ago. A really smart student at our university had epilepsy well controlled with valproic acid. She knew that she should start taking folic acid when she wanted to get pregnant, but nobody ever told her she should stop taking valproic acid. So she had a baby with spina bifida. But what happened? We weaned her off valproic acid, put her on lamotrigine, and in fact, her seizure control wasn't as good. So it's complicated, like most things in neurosurgery. Okay, so the take-home messages I want to leave you with before Sandip speaks to you. I think it's Sandeep, it's around about midnight, so I don't want to keep you up too much longer. Myelomeningocele is the commonest major congenital abnormality of the central nervous system. Please don't ever forget that an excellent quality of life is possible if you get these kids off to the best possible start in life. Don't forget that this condition is preventable. And as neurosurgeons, we have a really important role in making sure that that message gets across to the populations of our countries. It should be diagnosed antenatally, but often isn't, unfortunately. When these babies are born, we really need to aim for early closure and then make sure that they have proper multidisciplinary long-term follow-up. Remember adolescence. All of us going through adolescence is not easy, particularly not if you've got a medical condition. One of the most heartbreaking cases I ever had was a youngster who I'd managed from birth with spina bifida, who committed suicide as an adolescent because he really kind of, and this was 20 years ago, we hadn't really paid attention to the psychological support that these kids need, and just don't abandon your children when they kind of become adults and think that somehow life gets easier. It doesn't. And then remember that we have an important role as advocates for our patients. Okay, so on that note, thank you in all the languages of this wonderful panel. And thank you, Llewellyn. Thank you so much to you and Mohammed for the privilege of being part of this panel. Thank you very much.
Thank you very much, Graham. That was an absolute masterclass, and thanks for imposing an African perspective on really what is a global sort of disease burden and giving us those perspectives which we all really value. In the interest of time, I'm going to ask for one or two quick comments, and we will sort of merge that. So maybe Bello, if you're still on, do you want to maybe just make a comment, Bello?
Not really, except I'm glad Graham has emphasized the importance of a multidisciplinary approach to it. We have had this problem because this patient becomes a neuro patient, even though they have urological, GIT, and all orthopedics, all the problems. So really the younger guys out there, just make sure from the beginning you involve the other specialties. It is always mentioned, but it's never done. It remains a neuro patient, I know, but please, the multidisciplinary aspect is very important. Thank you very much for the opportunity and a great panel.
Thank you.
Thanks, Bello. Moody, some comments, just so we get a sort of African.
Very quickly. Thanks, Graham. I think you've highlighted some of the key and most important points, but just like ISPN has done, I think we should, and Bello might want to take that over as a project of CAANS when he takes over, hopefully soon, the presidency of CAANS, as a project to really through CAANS push the folic acid fortification agenda and combine it with the work that ISPN has done and ensure that CAANS can become responsible or take on that responsibility of pushing the various societies across the continent and try and reduce this burden of neural tube defects on our continent. Really, we shouldn't be constantly at every meeting be recognized as the world champions in the number of neural tube defects that we produce. We've really got to move on. And thank you very much for reminding us. And I think Bello's listening. That's a project for now, CAANS Bello, that we need to latch onto. And thank you again for the opportunity.
Thank you, Moody. Llewellyn and Mohammed, I think this is one for you to start thinking about, because really it's in the pediatric neurosurgery aspect. So please help us to start formulating or really putting together these ideas, especially the preventive aspect of neural treatment. Thank you very much.
Yeah, thanks very much, Bello. In the interest of time, I'm sure Sandeep's got some comments to make. I know India has a massive contribution to make in terms of neural tube defects. So I'm going to hand over to Mohammed just to introduce Sandeep and give him the opportunity to make some comments on this as well. Thanks, Mohammed.
Thank you, Graham, for this interesting presentation. And now, Dr. Sandeep Chatterjee. We're delighted to have Dr. with us. Sandeep set up the Park Neuroscience Service in 1995. This is now a DNB recognized training center in neurosurgery, as well as a whole spine recognized training center in spine surgery. He contributed over 58 articles in the national and international journals and 8 chapters in books. Presently, the editor-in-chief in the Journal of Association of Neuroscientists of Eastern India, associate editor of British Journal of Neurosurgery, and associate editor, International Journal of Neuroendoscopy and Hydrocephalus. He's on the editorial board of the Chapter Nervous System, Pediatric Neuroscience, Faculty for AO Spine, International Society of Pediatric Neurosurgery and European Society of Pediatric Neurosurgery, Asia-Australian Society of Pediatric Neurosurgery. He's presently an honorary secretary of the Indian Society for Pediatric Neurosurgery and educational chair of the ISPN, who is running a lot of webinars on the ISPN, very successful ones during this COVID time. He is a widely respected pediatrician in India and internationally, often invited speaker on conditions affecting the pediatric spine. We're Sandeep, and sorry for keeping you so late, and please go on with your presentation.
Okay, can you see my presentation?
Yes, very well.
Yes.
Okay, well, thanks to Mohammed and Llewellyn for inviting me to this very prestigious webinar. It is just past midnight in Calcutta. That's not a problem. The problem is that I have spent my last week with an oxygen saturation between 88 and 92%, not because I got COVID, but because I was spending my time walking at an altitude of 18,000 feet in the Karakoram Himalayas. But and I've just returned a couple of hours ago, so if I sound disorientated, it'll be the effect of having a sudden rise in my oxygen saturation. I will not say very much about open spinal dysraphism, because speaking after Graham Figan is a bit like trying to deliver the 11th commandment from behind the burning bush. I will stick to my remit of talking about closed spinal dysraphism. And as I've been instructed to try and do it within 20 minutes, I'm going to try and keep to time and go through this a little fast. Before I start, I need to acknowledge the contribution that 2 individuals have made to shaping my understanding of this subject. And this is a unique opportunity when I had an opportunity to dine with both of them. One is Professor Michel Gera from Paris, and a lot of the concepts of closed spinal dysraphism I'm going to share with you is based on what we have put together as a new classification, which we do hope will be published soon. And of course, the other man who has contributed immensely to our understanding of spinal dysraphism and who has actually seen this presentation and suggested changes to it, Professor Dakling Pang, and this was a unique opportunity when I had an opportunity to entertain both of them to dinner in Calcutta. So we have actually the first publication on spina bifida or spinal dysraphism by the same man who was made famous by the Rembrandt painting in the anatomy lesson, the famous Dr. Tulp. And a lot has happened since then. Why do we call this closed dysraphism? And what is closed in closed dysraphism? And the answer is, what is closed is this. What is closed is that the surface ectoderm, which is there, gives rise to these neural folds, which go up like that, join together, and then this neural tube separates from this cutaneous ectoderm, and that's what is closed. So what is closed is, in effect, the skin. And if you really look at these newborns with lumps on their back, you can clearly see that the fundamental difference between this one and the others is that this child has an open neural tube defect, which means that there is no skin cover, whereas all of the others, which go by various names. This is the open neural tube defect. This is a lipoma. This is an LDM. This is a neuroenteric cyst, and this is a double dysraphism. And the fundamental difference is therefore what is closed is that this dysraphic condition in all these, apart from this one up on the top left-hand corner, have skin which is closed. So what is closed is effectively you have normal skin cover. And I use the word normal skin because you can have abnormal skin, which is not the result of normal cutaneous ectoderm. So what's the fundamental difference between open and occult dysraphism? Well, open dysraphism is a CNS malformation, whereas occult dysraphism is a local regional malformation, which is genetic and very importantly is folic acid independent, unlike the open dysraphism, which is folic acid dependent, as you've just heard so eloquently from Graham. And of course, the open spinal dysraphism can produce myelodysplasia. The occult spinal dysraphism can manifest by producing compression, tethering, trauma, and myelodysplasia. And in our perspective, to try and understand the different types of closed spinal dysraphism or spinal dysraphism in general, one needs to go back and look at the development of the spinal cord. And the spinal cord develops through three basic processes: gastrulation, which is the formation of the primary germ cell layers. And what happens in gastrulation, of course, is that you have the epiblast and the hypoblast, and at the primitive streak, you have the hypoblast change into the definitive endoderm. Then there is the formation of the intraembryonic mesoderm, as we have an epithelial to mesenchymal transition, and we get the development of a three-layered embryo. This process, of course, is what is called gastrulation and forms the first step in the development of the spinal cord. The second stage, of course, is the neural tube closure. And we've heard a little bit about that already from Graham. But fundamentally, what happens in the neural tube closure is that after gastrulation, which I just told you, you have this epithelial to mesenchymal transition to form gastrulation. After gastrulation, the neural tube forms by a process called primary neurulation, which means, as I showed you in the cartoon a short while ago, the neural folds rise up, join each other, form a tube. This is called primary neurulation. And then there is separation of this neural tube from the cutaneous ectoderm by a process which is called disjunction. So the neural tube closure occurs in two steps: the neural tube formation, primary neurulation, and separation of the neural tube from the cutaneous ectoderm, a process called disjunction. And finally, the process of secondary neurulation occurs, where the caudal cell mass develops a canal which joins the bottom of the primary neural tube and forms the terminal spinal cord, the conus, the cauda equina, and the phylum, like so. So you have gastrulation to establish the three germ cell layers, primary neurulation to form the neural tube, disjunction where the neural tube separates from the cutaneous ectoderm, and secondary neurulation where the terminal spinal cord is formed. And if you can think of the anatomy like this, it is much easier to try and understand what can go wrong. Let us think about the problems. The problems of nomenclature in closed dysraphism, as indeed in open dysraphisms, is that we've constantly been changing the goalpost. This is a condition that 15 years ago we would call a dorsal meningocele. Today we call it an LDM. This is a condition that we would call a meningomyelocele Today we call it a terminal myelocystocele. So really, how do we understand all this complex nomenclature? And I think one of the key is from the embryologists. Although you will have to appreciate that most of our knowledge about the development of the spinal cord comes from cheek embryos, and indeed even worse from the Drosophila, and the highest we've reached is the rat, to try and understand the development of the spinal cord. And I really love this article published in Child's Nervous System years ago, which says, Pathogenesis of Diastomatomy. Can a surgical model in a cheek embryo gives clues about the human malformation? And I think the answer today is still probably not. Let's see what can go wrong. The first, what can go wrong with gastrulation, which you will remember is the formation of the three-layered mesoderm. Hence, the defects of gastrulation are generally ventrally placed. All germ cell layers are involved, and therefore there is skeletal anomalies in association with neural defects. And one of the problems of gastrulation, which produces a closed dystrophic state, is the neuroenteric cyst, which means there is persistence of the neuroenteric canal. It is worth trying to remember just one piece of embryological anatomy, and that is the neuroenteric canal, which communicates the yolk sac with the amniotic cavity, moves as it goes from cranial to caudal, moves from ventral to dorsal. What that means is if you get a neuroenteric cyst in the cervico-dorsal junction of the cervical spine, the neuroenteric cyst will be ventral to the spinal cord. Whereas if you get it in the dorsal-lumbar junction, the neuroenteric cyst has to be dorsal to the spinal cord by virtue of the direction of the neuroenteric canal. Okay. So what do you do with neuroenteric cysts once you've diagnosed them? Remember, they can have bony abnormalities. They can occur anywhere along the path of the neuroenteric canal. And the treatment is to remove the cyst and to untether the spinal cord. Much easier said than done. This is a girl that was operated 3 times for this neuroenteric cyst, came to us for the 4th operation. And when she came, she was 20 years old, an adult. It was 2010. She was in the 3rd trimester of pregnancy. She came with spastic quadriparesis, ended up with a respiratory problem. You can see this neuroenteric cyst has completely obliterated the spinal cord. She's already had 3 posterior surgeries done. And I just wondered, because she'd now become an adult, what could do. I had not been responsible for any of the first 3 surgeries. And we did something audacious, which we'd never done before. We went in from the front, took out a vertebral body, opened the dura, found the neuroenteric cyst, shelled it out, and then reconstructed her spine. That was the immediate post-op MRI and a 5-year follow-up. And indeed, now we have more than that. She's never had a recurrence. The other problem of gastrulation is the so-called split cord malformations, splitting of the notochord. And what happens is, because of the splitting of the notochord, there is induction of 2 neural plates. There is duplication of the spinal cord. And this is one of the first 4 paintings we have of a young boy with a tail, almost certainly a sign of a split cord malformation. We know that this has been classified by Professor Pang into a type 1 and type 2, depending on whether there is a single or 2 dural tubes, with the type 1s normally having a bony spur, the type 2 having a fibrous or a cartilaginous spur between the 2 spinal cords. But the basic embryological basis of this classification is simply this, that joining the neuroectoderm to this endoderm is this so-called endomesenchymal tract, which gradually regresses with time. And if you have an endomesenchymal tract, which is quite big and persistent, when the cells from the meninx primitiva, which forms the dura, comes close to encircle the 2 spinal cords, encounters this endomesenchymal tract, then 2 separate dural tubes are formed. Whereas if this endomesenchymal tract has regressed by the time the cells of the Mennings primitiva come to encircle the two neural tubes, you get one dural sac. So the type 1 and the type 2 split cord malformations is basically dependent on when embryologically the cells of the Mennings primitiva came to embrace the two hemicords. Again, because it's a disorder of gastrulation, it is often associated with skeletal anomalies like the 6-year-old with scoliosis who presented to us, the Cobb's angle being 70 degrees. Of course, we untethered the cord first, and then because we do not send our patients to orthopedic surgeons, with the pediatric patients, we fix the spine ourselves. So this is what we ended up with. And of course, split cord malformation untethering, which means we cut the phylum as well, and then waited and then fixed the spine. With the split cord malformation type 2, these are often much more difficult to do. These are the ones that we would not recommend prophylactic surgery for, unlike the split cord malformations type 1. And here the tethering element may be just a little bit of fibrous sheath attached to the dura and sometimes a septum like that. So the problems of gastrulation cause two major closed dysraphic states. One is the neuroenteric cysts and abnormalities of the neuroenteric canal. The second is the split cord malformations type 1 and type 2. Disorders of primary neurulation, I will not talk about because you've already heard about that from Graham Fegan. These are the ones that produce the so-called neural tube defects. What about problems of disjunction? Disjunction, you will recall, is the embryological separation of the neural tube from the cutaneous ectoderm. And two things can happen. The separation may be incomplete, so there is a connection between the cutaneous ectoderm and the neuroectoderm, or the separation may be premature, which means before the neural tube has closed, it decides to separate from the cutaneous ectoderm. And what happens in each case? If there is incomplete separation, you can get a dermal sinus tract or a limited dorsal myeloschisis, basically. A dermal sinus tract presents like this. That's a beautiful dermal sinus tract ending up in a dermoid cyst. And this is the connection that remained between this cutaneous ectoderm and the neuroectoderm. And the treatment, of course, is to identify that tract and divide it. And then there is the incomplete disjunction that produces the so-called limited dorsal myeloschisis. This is from the original article from Dackling. And there is incomplete fusion. The neural tube is still open when it separates, leading to this persistence of this cutano-neuroectodermal tract joining the cutaneous ectoderm with the neuroectoderm and having within it neural elements, unlike the dermal sinus tract that has squamous epithelium alone. And sometimes, if you're lucky and you work in a country like India, you can get two for the price of one. This is a 7-month female who came to us with 2 lesions. There's a hole on one side, there is a blue plaque on the other. So both of these are on 2 sides of the midline. Neither of them are in the midline. And of course, when you image them, you know what you're going to get. That's a diastomatomyelea spur with 1 tract on the right and 1 tract on the left. And then when we go in and untether them and remove both the tracts and untether the 2 hemicords, the one on the left is a dermal sinus tract. It's got a dermoid cyst in here. The one on the right has a neuroenteric cyst in it and is a limited dorsal myeloschisis. So you can sometimes get both of them together in the same patient. So, as I said, disjunction is the 3rd stage. An incomplete disjunction can produce either a dermal sinus tract or a limited dorsal myeloschisis. What happens if you have premature disjunction, which means that the neural tube is still open, it separates from the cutaneous ectoderm? What happens then is that this bit of mesoderm decides to come and sit on that open neural tube defect, much like ice cream on an ice cream cone. So you get a neural tube which is open, covered by mesoderm, and of course, an intact skin. And that produces the so-called classical dorsal lipoma. So a premature disjunction produces the dorsal lipoma. And when we look at these patients and look at an MRI like this, what as pediatric neurosurgeons we are thinking about is not the swelling in the back, but the fact that we have a dysraphic state where the skin is intact, there is a lump which is soft to firm, not cystic, but soft to firm, the mesenchyme that has come and occupied the opening of the neural tube. And because the neural tube is open, it can lead to a neurodeficit. And that's how the embryology makes it so easy to try and understand how these things develop and how they impact the neurology of the patient. And of course, this is a disorder of premature disjunction, and this is the genesis of the so-called dorsal lipoma. The caudal, transitional, or chaotic lipomas, however, are not problems of premature disjunction, but problems of secondary neurulation. And we'll come to that in a minute. And of course, the type of lipoma, which is completely a problem of secondary neurulation, which you will recall is the caudal cell mass developing a canal and joining the bottom of the neural tube, is the lipoma of the phylum, which is only 15% of lipomas. 85% are lipomas of the conus, and this is from the original article and presentation, and these slides are from Professor Ale Pierre Kahn from his original presentation, showing a dorsal lipoma and showing a terminal lipoma, depending on its location with reference to the position of the conus. And of course, the lipomas of the conus form 85% of the lipomas. This is a transitional lipoma. To these three, Professor Pang, and this is again from his original article that he published, they developed the concept of the so-called chaotic lipoma when the lipoma extends ventral to the spinal cord. So defects of neural tube closure, where there is incomplete disjunction, produces the dermal sinus tract and the limited dorsal myeloschisis. Where there is premature disjunction, it produces the dorsal lipomas. Defects of secondary neurulation produce these syndromes, the caudal regression syndrome, the Currarino triads, and of course the secondary neurulation syndromes are often associated with hindgut urogenital abnormalities as well. The caudal regression syndrome is completely a failure of secondary neurulation. And of course, Professor Pang has described this entity, the so-called retained medullary cord, which means that the spinal cord ends there, and then you get the phylum, and then you get a little bit of spinal cord at the bottom. Fortunately for most of us, this does not have any function. You can just simply chop it off. And the complex lipomas, as I told you a short while ago, are all defects of secondary neurulation. So, if we try and recall all the closed dysraphic states, gastrulation, neural tube closure, and secondary neurulation, that's how the spinal cord forms. And if we now decide that we want to put in the dysraphic spectrum, then defects of gastrulation produce the split cord anomalies and the neuroenteric cysts. Defects of primary neurulation produce the neural tube defects. Disorders of disjunction, where it's incomplete, produces the dermal sinus tracts and LDM. Premature disjunction produces dorsal lipomas. And of course, secondary neurulation disorders produce the complex lipomas, the trichid phylums, the myelocystoceles, and the caudal regression syndrome. To all this, Professor Pang has added a new concept, the so-called junctional defect disorders, which means the disorders that occur at the point where the secondary neurulation or the secondary neural tube, which is the caudal cell mass, joins the primary neural tube at its bottom. And the junctional defects are now known as the junctional neural tube defects, or JNTD. And this is one of the seminal articles that Professor Pang wrote to describe the various types of junctional neural tube defects. In the interest of time, I'm not going to go into the details of this, but you could read this very easily. But this is from that publication. And again, you can see the fact that all the problems occur at the junction of the bottom of the primary neural tube and the top of the caudal cell mass. Of course, we now know, as Professor Fegan showed you, it's not as simple as this. And the development of the spinal cord simply in the craniocaudal and its dorsoventral differentiation depends on a whole lot of factors. And if you simply look at the dorsoventral patterning of the spinal cord development, you know it's a balance between SHH and BMP. And I'm not going to go into the molecular genetics of this, but simply to tell you that it is not as simple and simplistic as we described embryologically. So the principles of surgery, and I'm not going to go into the details in the interest of time, is to understand the anatomy, to make sure that you untether the cord. If the filum terminale is producing a tethering component, it needs to be divided. In closed dystrophic surgery, we would always advocate using intraoperative neuromonitoring. And finally, you close to ensure you do not have a CSF leak. So in summary, to our simplistic understanding, the dystrophic states are best understood from an embryological perspective. Each can be associated with neurological dysfunction through a variety of mechanisms, but this scheme, which we think presents a unifying classification of these disorders based on the simple understanding of the basic stages of development of the spinal cord in human beings. Thank you very much for your attention, and I'll be very happy to answer questions.
Thank you, Sandeep, for this nice presentation. Any comments?
Yes, I believe Jose Salazar from Ecuador has a question. Go ahead, Jorge.
Hello. Yeah, thank you very much, Dr. Sandeep, for your excellent lecture. I have a question. How about the surgical correction of this defect before birth? What are your key points regarding this situation?
Well, the closed dystrophic states have not yet been treated with prenatal surgery. We've just had prenatal surgery limited to the open neural tube defects. So I guess there is no experience that I can draw on. The other thing is, of course, that most of these, with the sole exception of the dermal sinus tract, do not require a surgery immediately after birth. So for example, if you have a lipoma, and it's symptomatic, but the neurology is not progressive, you can certainly wait for the child to be 3 months old. So I think it's a little bit different from the open neural tube defect concept, where you try and operate early, prevent hydrocephalus, prevent the Chiari malformation, and try and get to that early.
Thanks. Thanks.
Sandeep,
Yeah,
if I may. I'm sorry.
You have comments?
If I may, this is Moody.
Please, Moody.
Yeah, Sandeep, if I remember from one of your slides, the closed ones don't seem to be caused by deficiency of folates. Is that correct?
Yes, absolutely.
And why do you think? Yeah. So, is there an why do you think that is the case? That it doesn't play a role?
Well, I think Graham answered the question. The actual contribution of folate is to work at the level of the so-called hinge cells, which basically contribute to the two neural folds getting angulated towards each other and then leading to the closure. So neural tube closure is what is dependent on folate. The other things like gastrulation, like disjunction, or like secondary neurulation are not controlled by folic acid at all. This is something that we before believed that folate stops all of this. Actually, putting folate in the diet only stops the open neural tube defects. It does nothing to the incidence of secondary neural tube defects. The closed neural tube defects.
So there'll be other causes such as perhaps...
Most of them are genetic. Almost all, as I indicated on that slide, almost all of them, the causes are genetic. And we've been able to now identify some of them. For example, disjunction we now know is caused by imbalance, as I showed you, and I just refer to this because that's a whole talk, imbalance between the SHH and the BMP factors that contribute to the dorsoventral development of the card.
Right. So perhaps the incidence is higher when there is intermarriage between family cousins and things like that, rather than.
Yeah, you may be right. You may be right. I don't think we have data yet to tell us this, but I agree with you. You may be absolutely right on that.
Thank you.
Graham, I think you have a comment. Graham still here? Yeah.
It's
Yes,
not midnight for him yet.
Yeah, so Sandeep, thank you very much. That really was just fabulous. And you simplify this very complex embryology in a way that makes it so accessible. So thank you very much. And I'm looking forward to seeing that classification system. So just a couple of comments. So firstly, maybe a silly question, but it's kind of weird that the vast majority of the central nervous system develops by primary neurulation, and then just the most caudal tip of the spinal cord develops by this completely different process of secondary neurulation. And I've never really seen a compelling explanation for why that is. I don't know if you have any thoughts about that after delving deeply into the embryology. And then just maybe more from a clinical point of view, given the fact that many of the people in this webinar would not necessarily have easy access to intraoperative neurophysiology. A lot of the surgery, when it comes to more complex forms of closed dysraphism, certainly in centers like yours and mine, are very much guided by intraoperative neurophysiology. So do you have any thoughts about how people should approach cases like this if they don't have intraoperative neurophysiology, and maybe link to that the question of whether what the clinical indications are? So patients who are asymptomatic, whether one should be embarking on surgery just because there's a bit like the Himalayas. Do you climb the Himalayas just because they're there, or do you have to have a reason? And then finally, you spoke about understanding the anatomy, and I think for me the single most important point to stress is you understand the anatomy by starting with normal. And I think that the biggest disasters with these kind of cases are when you dive into the pathologically abnormal part of the malformation, get completely lost, and then you don't know where in goodness name you are. So just to summarize, any thoughts about this crazy embryological thing about primary and secondary neurulation, indications for surgery, and particularly for people who don't have access to intraoperative neurophysiology, and then maybe specific comments about the surgical technique?
Yeah, I'll take your questions from the last one first. I think you've answered the question, what do you do if you don't have intraoperative neuromonitoring? I think the key is to understand the anatomy. And to my mind, the key to understanding the anatomy is to understand the embryology. If you understand the embryology, then you understand the anatomy. If you don't understand the embryology, it is impossible to work out the anatomy. So if you, for example, deal with something like an LDM, and if you remember Dackling's article, he's got these, 5 different classifications of LDM, each with subsections and subclassifications. That's fantastic from a descriptive point of view, but from a practical point of view, if you have a lump in the back which has a normal skin cover, we used to call these closed meningomyeloceles in the days gone by when life was simple and Dackling hadn't started writing all these things. Today, if you get a lump in the back, which looks like a meningomyelocele, but the skin is intact, that can never be a neural tube defect, because by definition, it cannot have a normal cutaneous ectoderm. So if your skin is intact, then it's got to be either a limited dorsal myeloschisis or something like a neuroenteric cyst if it's a cystic lesion. So, you know, the point is that if it is an LDM, you know that your basic aim is to identify the connection between the skin and the neural tube below and to divide that connection. So the anatomy, I think, is really the guide if you don't have intraoperative neuromonitoring. I do think it's very, very useful, but if you don't have it, understanding the anatomy through the embryology, I think is really something that we've been trying to emphasize, that the embryology should not be a method of making this more complex than it already is. It should be a method to make us understand the basic anatomy so that we can work on it. Second thing that you asked about prophylactic surgery. Well, of course, to my mind, one of the closed conditions, closed dystrophic states where I would always offer surgery is, of course, a dermal sinus tract. There is no controversy about that because every one of them, if you leave it behind, will have an infection. The prophylactic surgery, when would we offer? We would offer prophylactic surgery. I personally think I would offer prophylactic surgery to every split cord malformation type 1. With the type 2, I have to say there's a lot of controversy, but in my own experience, I would wait and watch for a type 2 split cord malformation. These are much more difficult to do, particularly without intraoperative monitoring. I would never touch a type 2 prophylactically unless it produces symptoms. I'm not going to go into the lipoma debate, but I think most of us would now offer prophylactic surgery in dorsal lipomas as well, perhaps not in transition, certainly not in chaotic lipomas, where we could make things a lot worse than they are. The question about embryology of the caudal cell mass, I think the real key here is that the caudal cell mass is a very compact bunch of cells put together. And the problems that occur, as we've understood now, is in fact, more problems occur at the junctional zone. And the junctional zone problems occur because the so-called caudal cell mass develops a secondary neural tube, which goes and joins the bottom of the primary neural tube. But one of the first examples of programmed cell death or apoptosis that occurs in the embryo occurs at the top of that secondary neural tube, which joins the bottom of the primary neural tube with these two canals uniting to form one canal. And I think the problem occurs because this little bunch of cells of the caudal cell mass, if you think of it, innervate so much. They innervate the sphincters, they innervate the bladder, the anal sphincter, they innervate the lower limbs because that produces the conus. Yep. So I think that's really why we get so many more problems from the secondary cell mass and the junctional zone compared to the primary neural tube. I don't know whether I've answered your questions. These are just random thoughts.
Thanks, Sandeep. No, that's very compelling. Thank you.
Yeah, Llewellyn, you're still here.
Yeah.
So,
no, look, I think
you want to wrap up? Yeah.
Sure. Look, thanks, Mo, and thanks, John. I think we haven't sort of made that point. Thanks, John, for all the logistic efforts in distribution and putting together, all of these. John, do we have any comments, by the way, that you want to highlight from the chat session?
Well, did you look through there's a couple of chat comments.
Yeah.
Okay, these are kind of general questions. I wonder if you could go through them, Llewellyn, to kind of prioritize them.
Yeah, so look, thanks, John. I've been through them. A lot of them are just comments. And I think in the interest of time and consideration really for Sandeep more than anyone else, I think we'll start to wrap things up. So really, thank you to all our speakers. Thanks to Girish. Girish, any comments quickly, I think from your side might just give us a different perspective on these spinal dysraphisms. Maybe just a quick comment before we wrap up, Girish, if you're still around.
Yeah, Llewellyn, I thought, both presentations were compelling. And I thought some of the questions that were asked were quite interesting as well. One of the things I'd say, it's, of course, Graham made a very important point, why the second neurulation happened differently. I think part of it is probably because of the development of the chora equina, which is required in secondary neurulation. And that, of course, is peripheral. You could consider it as slightly different from formation of solid cord. So the caudal and sacral cord then attaches to the primary neurulation. And, Sandeep also made comments about the junctional zone and so on. One of the questions I really liked was, I think came from Niger, about the multidisciplinary management of closed dysraphism. So I think spina bifida, of course, everybody is familiar with urological and orthopedic management of open spina bifida, and that pretty much happens with every child. But I think there is equally need for multidisciplinary care in a lot of the closed dystrophic patients as well. So the lipomyelomeningocele is often, in a way, orphaned because they don't get immediate care. They are closed, they are hidden, but they do suffer orthopedic urological problems, which are often unknown or not diagnosed. So most of them have constipation. They go through all sorts of gastroenterology investigations and so on and so forth, until finally the penny drops and they find that the kid has a tethered cord and so on. So I think all of that requires some forethought, and perhaps the spina bifida clinics should consider more thorough treatment of closed spina bifida as well. And Graham's point about intraoperative monitoring is also critically important. I think it is very helpful. I use it all the time. But before we started using the modern methods of continuous intraoperative neuromonitoring, we used to use the simple sort of EMG machine to use the probe to identify which were the nerves that, or where was the fatty phylum. So I think even in a basic sort of environment, it could do some form of monitoring. And it doesn't have to be very complex or very, extensive. And it may be sort of, based on what you need for that particular procedure. So I'm going to stop here now. And then fantastic meeting. Thank you very much for inviting me.
No, thanks, Girish. I think those thoughts really round things off beautifully. So it gives us a sort of a more global perspective. So I'm going to start to wrap things up. So thanks to our speakers. Thanks, Sandeep. That was really a masterclass, lecture. Thanks so much for staying up this late, and we hope your oxygenation levels sort of peter out at a normal level. So thanks so much, Sandeep. And thanks, Graham. Again, fantastic. Thanks so much for imposing an African perspective and giving us really a sort of balanced view on this complex phenomenon. And then Girish, really, I mean, your experience and insight into this condition are really sort of growing. Every time I hear you give this talk, I'm sort of really sort of blown away by your insights. So thanks so much. And then thanks, Mohammed, who co-hosts these sessions with me on behalf of CAANS, and for the support. Thanks to Moody Qureshi and Bello Shehu. Thanks so much for your support for these things. Our next webinar will be, Mohammed, correct me, I think it's it's the second Tuesday of every month, which will be the fourth Tuesday. Yeah. Okay, so thanks so much, and thanks to all our attendees, and we seem to be developing quite a sort of regular following. And I'm going to end there. Mo, I'll just hand it over to you just to wrap up and close off.
Thanks, John, and thanks everyone for this interesting webinar. Of course, thanks for all the speakers and the attendees. And thanks to Sandeep for keeping me so late.
Okay, I'd like to thank everybody. Thanks, Mohammed. Thanks, Llewellyn, and we'll see you in 2 weeks.
Thank you, guys.
Thank you, guys. We'll see you in 2 weeks.
Thank you. Thanks, Bello. Thanks, Moody. Yeah. Bye. Bye, everyone. Bye-bye.
Okay.